Welcome. In today's video, we're going to be reviewing the Basic Life Support or BLS Practice Examination. My name is Eunice Mathis. I'm a registered nurse and the owner of Florida Training Academy, and let us go ahead and begin. Number one, you work with an overweight 55-year-old dentist with no known history of heart disease. He begins to complain of sudden severe crushing pain under his breastbone in the center of his chest. The pain has lasted more than 5 minutes. What problem should you think of right away, and what should you do? The options are A, you're going to think that it's heartburn and tell him to take an antacid, or B, you're thinking that it's angina or angina, which is chest pain caused by a cardiac issue, and you're going to have him phone his personal physician right away. C, you're going to think that it's caused by a heart attack and phone 911. Or D, you're thinking it's an arrhythmia or an abnormal heart rhythm, and you're going to drive him to the emergency department. Severe crushing pain. If you chose C, you're suspecting that the doctor's having a heart attack and you're phoning 911. That is correct. For an emergency, we don't take our patients to or call the doctor, because the doctor's going to say, hey, you need more treatment than what I can provide, so we need you to go to the ER. And the safest way to transport that person to the ER is by calling 911. Number two, you witnessed the collapse of a 45-year-old man. You are now performing CPR after sending someone to phone 911. You have done your best to ensure that the first two links in the chain of survival have been completed immediately. What is the third link in the chain, which will have the greatest effect on increasing this man's chance of survival? If you're not familiar with the chains or the chain of survival, usually your BLS manual or in your BLS course, your video will show you. And I'm also going to show you on the subsequent page, but let us go ahead and read through the options. A, arrival of paramedics who will administer drugs. B, transportation of the man to a hospital. C, arrival of a rescuer with a defibrillator. Or D, arrival of EMS, which would be the emergency medical services, or the paramedics, arrival of EMS personnel who can do CPR. What is going to have the greatest effect to increase the chances of survival? And remember, you're already doing CPR. All right, so the answer is going to be C, arrival of a rescuer with a defibrillator. And even though I know we have the 6 links there, right beneath it, I do have the information. And so this comes directly from the American Heart Association. The first link is the activation of the emergency response system. And so that's going to be you calling 911. And this is for the out of hospital arrest. So if this happens in the home or the community versus a hospital. Second is, so you've called 911 and you've started high quality CPR. So CPR will be the second link. The third link in the chain of survival is going to be rapid defibrillation. So let's get that AED there as soon as possible so we can try to get this person's heart back into a normal rhythm. And then after that, we're going to, it says advanced resuscitation. So when those paramedics, when those firefighters, when they come, usually they know advanced cardiovascular life support. So they can start IVs, give emergency drugs. If necessary, they can even intubate the patient. Post-cardiac arrest care. And so now that they've been transferred to the hospital and they have a pulse, our job is to make sure they don't re-arrest. So we're going to find out the cause of their, cardiac arrest. Was it due to hypoxia or low oxygen? Was it due to blood clots? We need to figure out the cause, treat it appropriately, and then that is hopefully going to prevent the person from going back into cardiac arrest. And then lastly, recovery. When you think of recovery, after someone has had a major life event such as cardiac arrest, it's going to take their body time to get readjusted. They're going to be getting tired fast. So recovery not only includes the mental and emotional support, but it also includes cardiac rehab. Next, number 3. You have been talking with a 60-year-old man. He is alert and has been conversing normally. All at once, he complains of a sudden weakness on one side of his face and in one arm. He is also having trouble speaking. What is the most likely cause of his problem? A seizure. B, a heart attack. C, a stroke. Or D, diabetic coma. If you said C, a stroke, you're absolutely correct. And so strokes or cerebral vascular accidents are caused by either a blockage or a bleed in the brain This is a medical emergency. Keep the person calm. You can do the FAST assessment. FAST is look at their face. One part will probably be drooping, which means it's asymmetrical. You can ask them to raise their arms. More than likely, one arm won't raise as high as the other. You can ask them to say their name so that you can hear them speak. Normally, it's going to be garbled. So that will be assigned to T. Call for help. Time to call 911. So let's do our FAST assessment again for strokes. Face, arm, speech, time to call. Keep the person comfortable. Do not put anything in their mouth. Don't give them anything to eat or drink. And when they get to the hospital, we'll find out the cause of their stroke and then go ahead and start the appropriate treatments. Number 4. You remove a 3-year-old from the bottom of the shallow end of a swimming pool. You find that she is limp and unresponsive. No other person is available to help. When should you phone 911? A, after you have given the child 2 minutes of CPR. B, as soon as you remove the child from the pool. C, when you see that after several minutes of CPR, there is no response. D, after giving a few ventilations or breaths and before beginning chest compressions. So this was an unresponsive child who's in cardiac arrest. When do you phone for help? The answer is A, after you've given the child 2 minutes of CPR. So for pediatric arrest, normally it's not caused by their heart, it's caused by their lungs. So in this case, the child drowned more than likely. And so the lungs are filled with the pool water. I need for you to go ahead and do 2 minutes of high quality CPR, which would be about 5 cycles. And that's going to make sure that you're perfusing the oxygenated blood that's still within their body. When you do those chest compressions, we're perfusing blood to the brain. If you have your cell phone, well, then, it's going to be a little bit easier because you can just pull out your cell phone, call 911 and do CPR while the rescuer is on the phone with you. However, this was not the situation for this particular question. You didn't have a phone there with you. So you'd have to do 2 minutes of CPR, get some blood flowing, and then leave to call 911. If the child is of a size where you can pick them up and take them with you, then by all means, please do so. Number 5, you are a medical advisor helping set up a public access defibrillation program at a local shopping mall. The mall has purchased an AED. The mall personnel director asks, if AEDs are so foolproof, why do security guards have to learn CPR and be trained to use the AED? Which of the following is the best explanation for the need to train rescuers to perform CPR and use an AED? All right, so A, rescuers don't need to learn CPR if they can use an AED. B, rescuers need to be able to verify the rhythm analyzed by the AED. C, rescuers need to know when and how to use the AED safely and how to perform the steps for CPR for unresponsive victims who are in cardiac arrest. Or D, rescuers will need to learn to maintain the AED and repair it if something goes wrong. And so what do you think the responsibility will be for mall personnel, such as security guards? Do you think they're repairing AEDs? Do you think we're going to teach them how to analyze heart rhythms? All right, and so if you said no, you're right. The correct answer is C. Those rescuers need to know when and how to use the AED safely and to perform the steps of CPR for unresponsive victims who are in cardiac arrest. And if you're enjoying the video so far, don't forget to subscribe to our channel. Florida Training Academy is a nurse-owned CPR and safety training company. We have so many videos, whether it's ACLS, BLS, PALS, and also CNA to help our students pass their exams and get to the next level. So please like, subscribe, and share. Continuing, number 6, you are responding to an emergency call for a child who was found unresponsive in her bed with no sign of trauma. Unresponsive in the bed, no trauma. How should you open her airway? A, place your fingers in her mouth and pull forward on the lower jaw. B, do the jaw thrust maneuver. C, tilt her head and lift her chin. D, pull her tongue forward. All right, so what's the best answer? If you said C, tilt her head and lift her chin, you're absolutely correct. There was no trauma, so you're just going to do the traditional head tilt and chin lift. Make sure you squeeze the nostrils before you administer those 2 breaths. If you don't squeeze on the nostrils, the air is going to escape the nostrils whenever you breathe into the victim's mouth. 7. Before providing rescue breaths for an unresponsive victim, you must check for breathing. You do this by listening and feeling for airflow through the victim's nose or mouth, and by A, looking into the victim's mouth to see if anything is blocking the airway, B, shaking or tapping the victim's shoulder to stimulate him to breathe, C, checking the pupils, or D, looking to see if the chest rises and falls as the victim breathes. All right, and this is an easy one. The answer is D, looking to see if the chest rises and falls as the victim breathes. And if there is no chest movement, you are to assume that the person is dead. And of course, for BLS personnel, we also will be feeling for a pulse. But if the chest is rising and falling, check for the pulse. If there is no pulse, make sure you begin CPR. Number 8, you're in a hospital cafeteria where a woman appears to be in distress. She is grasping her throat with both hands. What should you do to find out if she is choking? A, give her 5 back blows. B, give her 5 abdominal thrusts. C, ask her, are you choking? And be prepared to provide 5 abdominal thrusts. Or D, shake her and shout, are you okay? All right, you want to get permission, so the answer is going to be C. You're going to ask her, are you choking? And of course, if she says yes, you're going to go ahead and give those 5 abdominal thrusts. And you would continue those abdominal thrusts until the object is expelled or until the person actually becomes unconscious. Number 9, you are providing rescue breaths for a child using a bag mask device. What action will confirm that each of your rescue breaths is adequate? You're giving her breaths using the bag mask device. How do you know that what you're doing is actually working? A, you're going to determine the child's weight, calculate the tidal volume, and deliver the amount of air. My babies, my babies, my babies. That sounds like that's above your pay grade. Remember, this is basic life support. If you have to know what tidal volume is, more than likely that's advanced life support. All right, and so B is observing the child's chest rise with each rescue breath. That one sounds more logical. C, choosing the correct bag mask device, which will ensure delivery of adequate breaths. But sometimes there's equipment failure. So just because you choose the right size doesn't ensure that the actual breaths will be going through. So I'm still thinking about B, observing the child's chest to see if it rises with each rescue breath. Or then D, delivering breaths quickly with high peak inspiratory pressures. And again, if it's some big word, more than likely that's ACLS, and that's above your pay grade for BLS. All right, so let's see what the options are or what the answer is. And the answer is B. You're going to observe the child's chest rise with each rescue breath. And I want you to notice there, in the hospital, you may call those ambu bags, but for most national standards, such as the American Heart Association, they won't refer to a brand name such as Ambu, a maker of a bag mask device. But what I want you to see here is that there are different size bag mask devices. And so the larger one is for adults. The one in the middle would be for your pediatric population for children. And then, of course, the one on the very end is for infants. And so you want to make sure you have the appropriate size bag mask device and that you're checking for chest rise whenever you administer a breath. Number 10, what is the correct depth of chest compressions in an adult? A, as deep as possible. B, up to 2 inches. C, between 2 and 2.4 inches. Or D, at least 3 inches. How deeply do we compress? All right, if you said C, between 2 and 2.4 inches, you're absolutely correct. You'll also hear us say 1/3 the anterior posterior view of the chest, or that side view of the chest. So if you have a very obese patient, we can't be compressing 2 to 2.4 inches. We want to bring that chest 1/3 of the way in. 11, how long should a pulse check last? A, as long as it takes to find a pulse. B, no more than 2 seconds. C, no more than 5 seconds. D, no more than 10 seconds. How long can you take to find a pulse to determine if you need to start CPR? That answer is D, no more than 10 seconds. And 10 seconds is a common answer for the American Heart Association's basic life support exam. So no more than 10 seconds. 12, where should you check for a pulse in an adult? A, carotid artery, B, brachial artery, C, femoral artery, or D, radial. Carotid is the neck, brachial is the arm, femoral is the thigh, the hip area, and then D, radial would be the wrist. So whenever someone's in cardiac arrest, we're not going for distal pulses. We need to be closer to the heart. So which of those would be closest to the actual heart itself? And that answer is going to be A, the carotid artery. And so if you notice there in the image, it shows that we're on the side of the neck where the groove of the neck is, and we're going to press in. We do not use our thumb. We use our index and our middle finger. And you can also use your ring finger if you need, but 2 or 3 fingers excluding the thumb, and you're going to be holding it for no more than 10 seconds. If you don't feel a pulse, we're going to go ahead and make sure we call out for that AED, and we're going to start our high quality CPR, beginning with chest compressions. 13, where should you check for a pulse in an infant? A, carotid, B, brachial, C, femoral, or D, radial. And now infants are a little bit different because of their anatomy. So the correct answer is going to be the brachial artery. And so infants usually have a larger head, so it's really hard to find their neck. And so it's going to be harder for you to locate that brachial artery, harder for you to locate the carotid artery. So the best rule of thumb is just to use the brachial artery, which is in the inner aspect of the upper arm where the check mark is right here, okay? 14, a child is gasping for breath, but has a pulse rate of 100 per minute. The rescuer should A, start CPR beginning with compressions. B, give 1 breath every 6 seconds. C, give 1 breath every 2 to 3 seconds. D, do nothing. The child is not in distress. All right, so the statement says the child is gasping for breath. That is abnormal. That is a sign of a medical emergency. So D is not the answer. We're not going to watch a child gasp for breath. They have a pulse rate of 100. So their heart rate's okay. What we want to do in that scenario is supplement oxygenation. So we don't have to do A. We don't have to start chest compressions because their heart rate is okay. They're still alive, but they're gasping for breath, and we're not going to do D. We're not going to do nothing. So how frequently do you give a rescue breath to a child? Is it 1 breath every 6 seconds or 1 breath every 2 to 3 seconds? Good job. If you said C, 1 breath every 2 to 3 seconds, you're absolutely correct. And remember that if we're trying to prevent a cardiac arrest in a pediatric, in a child or an infant, we need to supplement that oxygen. Because if they were to go to cardiac arrest, usually it's not due to ventricular fibrillation or an abnormal heart rhythm. It's more than likely their airway. Maybe it's anaphylaxis. Maybe it could be something's in their actual airway. So we want to make sure we supplement and give those breaths. And it's going to be 1 breath every 2 to 3 seconds. Number 15, a child is not breathing, but has a pulse rate of 50 per minute. The rescuer should A, start CPR beginning with chest compressions. B, give 1 breath every 6 seconds. C, give 1 breath every 2 to 3 seconds. D, do nothing. The child is not in distress. Going back to the question. The child is not breathing, so obviously the child is in distress, so it's not D. Now the difference is in the last scenario, the child had a pulse rate of 100. According to the American Heart Association standards, anytime a child or an infant has a heart rate less than 60, with signs of poor perfusion. So normally poor perfusion, I hear a lot of students say cyanosis or turning blue, but I'm African American and I don't turn blue. My son would not turn blue. Neither would a dark-skinned Asian, dark-skinned Latino. We're not going to have that type of color change. So one of the best things to check for is going to be the capillary refill. And if it's taking longer than 2 to 3 seconds for the blood to refill into our nail bed, that would be a sign of poor perfusion. Others may say you can check the gums. I don't know if the gums are naturally dark, so I'm not going to be checking the gums. I'm more than likely just going to look at the skin, look at how this child is responding. Right now, this child isn't breathing. Heart rate is 50. According to American Heart Association standards, we do not wait for a child or an infant's heart rate to be 0 before we start CPR. Remember, they breathe faster than adults and their heart beats faster than an adult's. So by the time their heart rate gets to 50, that's close enough to 0 for me to start CPR. So the correct answer for 15 is A. We're going to start CPR beginning with chest compressions. 16. A 70-year-old man who has been eating steak in a restaurant abruptly stands up and grabs his neck. The rescuer determines that the victim is choking. The best response is to A. Use back blows. B. Do nothing. Wait until the victim becomes unresponsive and then start CPR. C. Use abdominal thrust. D. Use upward chest thrust. All right, what do you do if someone stands up, grabs their neck, and they indicate that they're choking? You're going to do C. You're going to use abdominal thrust, formerly referred to as the Heimlich maneuver. 17. An infant who has been choking becomes unresponsive. The rescuer should. And this is going to help you on your American Heart Association Basic Life Support examination. Anytime a choking victim becomes unresponsive, they have lost so much oxygen until they're no longer moving. We're going to assume the person's dead and start CPR. But let's go through all our options. Anytime, regardless of the age, anybody who is choking, when they stop moving, they become unresponsive, unconscious, we start CPR. But here we go. Options are A, alternate back slaps and chest thrust. If they were still moving, yes, but this infant is no longer moving, they're unresponsive. B, perform a blind finger sweep to attempt to remove the obstruction. We never perform blind finger sweeps. You'd only do a finger sweep if you could see the obstruction. C, attempt to dislodge the obstruction using abdominal thrust. And again, it's too late to try to dislodge anything because at this point, the infant is now unresponsive. We need to focus on circulating whatever oxygen is still within their system. And we're going to do that by D, beginning CPR. And the reason why I have that image there is because most of you all know about the 2-finger technique, but in our classes, we notice that especially if someone has arthritis or their fingers may tire really fast, or even though we ask them, as a healthcare provider, not to have on those fingernails, sometimes those fingernails are long and they get in the way too. So another technique they can use is they'll wrap the 4 fingers around the back, make sure the infant's actually on a flat surface, and then the 2 fingers will meet in the front, in the center, and they can do their compressions that way, and it seems to be less taxing on our students. And we call that a 2-thumb encircling hand technique. Number 18, efforts to relieve choking should be stopped when A, the obstruction is removed, B, the victim becomes unresponsive, C, the victim begins breathing normally, D, when any of the above occurs. When would you stop your efforts to help a choking person? And if you chose D, any of the above, you're absolutely correct. And so you all, we have multiple playlists. And so we also do CPR and BLS, ACLS, and PALS instructor courses. We're located in Jacksonville. And so what we can do normally is if you fly in on a Friday, of course, we get everything pre-planned. You stay overnight. We can get your instructor course completed on a Friday, and then we can have you monitored on that following day, Saturday, and you can fly out and you be an American Heart Association instructor. I like to think we're worth the drive. So again, our website is fltraining.com, and this is Eunice Mathis with Florida Training Academy. Let's continue. We have a few more questions. Number 19, in which of the following situations is in which of the following situations is moving a patient during CPR appropriate? When we move a patient during CPR, so this person's in cardiac arrest, A, the patient is lying on his stomach. B, the patient is in a burning building. C, the patient is on a soft mattress. D, the patient is in a place or position where you cannot do effective CPR. Or E, all of the above. When is it appropriate to move a patient? If you say E, all of the above, you're absolutely correct. If you're in the hospital, when you call that code, you can go ahead and press that CPR mode on the bed. That usually that will allow the head of the bed to go flat. The air escapes the mattress. Of course, you've called for help. You've pressed the code button. You start your compressions on top of that bed. And when your team comes with the backboard, you do a lift, put the board under them. You continue your CPR. Sometimes with patients who are on COVID, they may be in the prone position, meaning that they're face down. So you would have to reposition that person, put them back on their back in order for you to start CPR. And the reason why I have this image here of a transfer is if there's a mass casualty event, some things that we don't talk about in BLS, and so I want you to confirm this with your firefighters, your paramedics, your EMS personnel, is that we have to focus on those who have a greater chance at survival. And so if we have somebody who may be hemorrhaging because they were injured, somebody else who may be having a respiratory issue, and someone who's in active cardiac arrest, which would you see first? What I can tell you is the one that you'd see last. The one that you'd see last is the one who's in cardiac arrest, because I need to help those who have a greater chance of survival. And so for basic life support, we really don't cover that, but I want you to keep that in mind, especially in these times that we're in right now, is that if there are 5 people who need aid, I need you to focus on the 4 who have the greatest chance at survival. And then if you have time to go back and do CPR, by all means do so. And if you could pull that person to safety, by all means do so. But otherwise, please focus on those who would have, again, the most chance at survival. If you're by yourself, if you can delegate someone else to assist, please do so. Number 20, in 2 rescuer CPR, where the patient is between 1 year old and puberty, the chest compression to breath ratio is. So let's talk about that. 1 year of age to puberty. What are signs of puberty? Breast development, underarm hair. And my rule of thumb is if I'm looking at this child and I've seen adults who are the size of this child, because even my son right now, he's 11, but he is a big 11. So as far as his height, so you want to be thinking about that cutoff point. So if the child has reached puberty and there are 2 rescuers, what is going to be your ratio of compressions to breaths? Is it going to be 15-1, 15-2, 30-1, or 30-2? 2 rescuer CPR on a child. The answer is going to be B, 15-2. And let's talk about the reasons why. And I'm just going to go through these numbers quickly. The compression rate for all ages, adults, children, and infant, across the board, 100 to 120 beats or compressions per minute. If it's 1 rescuer, a single rescuer, regardless of the age of the victim, it's going to be 30 compressions followed by 2 breaths for 5 cycles or 2 minutes, or until help comes to relieve you. However, you have 2 or more rescuers and it's an infant or a child victim who's in cardiac arrest, we want you to switch your ratio from 30-2 to 15-2. And the reason why is because of the cause of the pediatric arrest. Usually, again, I said it before, if a child or infant goes into cardiac arrest, it's not their heart that was the cause, it was their lungs. And kids already breathe faster than adults anyway. So when you switch to 15-2, you actually end up giving double the quantity of breaths in the same time frame, because instead of doing 5 cycles in 2 minutes, you actually end up doing around 10 cycles in 2 minutes. So instead of giving 10 breaths, you give 20 breaths. And we're trying to provide that supplemental, that extra oxygen in order to help reverse this cardiac arrest in a pediatric victim. Number 21, over what age should you use adult AED pads? Is it 8 years of age, 12 years of age, 18 years of age, or 21 years of age? At what point do we transition from child to adult AED pads? And according to most manufacturers, it is 8 years of age. And you all, I really don't even know what an 8-year-old looks like, because again, my son was always tall for his height. And so this is supposed to be a picture of middle schoolers, which I think is appropriate. But again, if you're overthinking it, if you're like, oh my God, I don't know if this is a child or an adult, again, follow up with your paramedics, your firefighters, the people who are in your community that you trust. But I'd rather do more than less. So if I can't determine whether or not this is an 8-year-old, I'm just going to go ahead and use the higher level, okay, if there's not a parent or someone there who can assist me. Regardless whether it's the pediatric pads or the adult pads, if at any points the pads look as if they're going to touch or overlap, that's a no-no. So you wouldn't be able to use the images that are on the pads at that point for your pad placement. The pads cannot touch. What you do instead is you put a pad on the center front and a pad on the center back. Of course, if I'm saying anything that differs from the manufacturer or your director, refer to your director of your emergency services or the manufacturer of your defibrillator. And also, whenever you do take your BLS course, your instructor should be able to support the information that I just provided to you. Number 22, what is the recommended length of time for a pulse check? Is it A, 5 seconds, B, 10 seconds, C, 30 seconds, or D, as long as necessary? And we should know this. How long do you have to feel for a pulse or to begin CPR? Yep, 10 seconds. Great job, everybody. 23, what is the approximate rate of compressions in adult CPR? I gave this to you. You should know it. Is it 60 compressions per minute, 80 compressions per minute, 100 up to 120 compressions per minute, or is it 60 to 100 compressions per minute? At what rate do we provide compressions in an adult? All right, if you said C, 100 up to 120 compressions per minute, you're absolutely correct. We find that if you go faster than 120 compressions per minute, you do not allow the chest to recoil. And whenever you allow that chest to come back up to its normal position, you give the heart time to refill with blood. So if you're going so fast and you're just doing a whole bunch of work, you're not being effective. When we compress on the heart, we circulate the blood. When we let that chest recoil, we allow the heart to fill up with blood again. So you want to try to keep your rate between 100 to 120 per minute. Don't forget that for an adult, our compression depth is 2 to 2.4 inches. And we're going to do 30 compressions followed by 2 rescue breaths. Number 24, which of the following is not a component of high quality CPR? A, at least 100 chest compressions per minute. B, minimum interruptions in CPR. C, allowing complete chest recoil of, let me repeat that. C, allowing complete recoil of the chest. And then D, all are components of high quality CPR. What are your thoughts? Absolutely correct. Everything there was a component of high quality CPR. And we're just going to do our recap. Remember the rule of thumb, the 10s. We need to start compressions within 10 seconds. So that means that we get 10 seconds to feel for that pulse. And then we're going to push hard and fast at a rate of at least 100 up to 120 compressions per minute. If it's an adult or a child, we can compress 2 inches. However, if it is an infant, we're going to compress at least 1.5 inches. We just discussed allowing for a complete chest recoil so that we give the heart time to refill with blood, and we're going to minimize interruptions. I don't care what happens. Your AED doesn't work. There's equipment failure. I need you back on that chest within 10 seconds. Whenever you're giving effective breaths that make the chest rise, you don't want to hyperinflate the chest. You don't want to give a really big breath, because if you do, that extra air could go into their stomach and it can cause them to vomit. But what else it will do is it will decrease cardiac output, because now their chest wall, their chest cavity, their lungs is full of this oxygen, which means that when you go to compress, your first few compressions won't be as effective because it's all of that air trapped in their lungs. So we want to make sure that we only give a breath that results in a chest rise, not the stomach rising. And then 25, and then I have 2 bonus questions for you. What does the AED stand for? Is it A, automatic energy delivery, B, automated external device, C, automated external defibrillator, or D, autonomous energy defibrillator? What does the AED stand for? If you said automated external defibrillator, you're absolutely correct. And remember, it's going to deliver energy, which is going to try to normalize the heart's rhythm. Bonus question, can you use an AED on a pregnant mother? You absolutely can. Whatever damage you think that AED, the shock, is going to provide to the baby. Right now, mom's heart is just quivering. It is not producing any contractions. So the placenta that's feeding the baby is not getting blood flow. The baby is dying because mom's heart is not moving. We need you to use the AED on mom so we can try to get a blood flow, a pulse again, that heart contracting again, so we can start feeding the baby again. So yes, you can use the AED on a pregnant mother. Next question. Can you use an AED on someone who has an implanted defibrillator? So Papa has an incision here, elevated area. He says, if something ever happens to me, you don't have to use that AED on me because I already have a defibrillator. Is Papa right or wrong? All right, and unfortunately, he's incorrect because those batteries and those implanted devices usually last about 10 years. It could be a little more, a little less, but if someone does have an implanted device, you still want to use the external defibrillator. You just don't want to put the pads directly on top of whatever implant device they have. And most cardiologists, most cardiovascular surgeons know to put the AED on the left side whenever they can. And of course, your AED pad will go on the right. High area, and then the second pad would go left a little bit beneath the breast line. And guess what, everybody? We did it. We reviewed 25 questions in preparation for your BLS, your basic life support examination. Again, this is Eunice Mathis with Florida Training Academy. Our website is fltraining.com. On our YouTube channel, which is Florida Training, we have dozens of videos. So whether it's CNA, CPR, BLS, ACLS, PALS, whatever you can think of, we're here to help you pass your exams and get to the next level. So you all be blessed. Don't forget to subscribe, like, and share. Bye-bye, everybody. Hello, everybody, and welcome. My name is Eunice Mathis. I am the owner of Florida Training Academy and also a registered nurse. In today's video, I'm going to be showing you how to manage an unstable patient who has bradycardia. For most purposes, or especially if you're a nurse, bradycardia is when the heart rate's usually less than 60. However, for ACLS purposes, when you look at your ACLS algorithm, American Heart Association recommends that we treat bradycardia when the heart rate is less than 50. As a reminder, someone may have a heart rate that is lower than normal if they are athletic, maybe just due to genetics or certain medications. So if a patient is symptomatic, they could be short of breath, dizzy, having blood pressure issues, and has a heart rate less than 50, we're going to treat. So I'm going to go ahead and start our scenario. All right, so you enter the room and you see on the monitor that the patient has a heart rate of 42. I'm going to go ahead and pause it just to give you time to think about the processes and who do you want to call in the room. You're going to actually start doing a brief but focused assessment on your patient. And if you don't know this patient's medical history, you're going to start asking questions. I'd definitely be concerned about maybe a recent surgery. It could be blood loss, any medications the patient could be taken, could be the LOL, some beta blockers. Is the patient on digoxin? I would also go ahead and start calling my team. And so even though I'm teaching this in silos, as I said in another video, this would be more fluid in the real world, but we're just going to go through it. We've recognized that our patient has a slow heart rate. Heart rate's 42. We're not dropping any beats, so it is a sinus bradycardia. The temperature is 98.6. Once you call the team into the room, what task are you going to delegate to the CNA? More than likely, your CNA or your patient care tech is going to go ahead and get a full set of vital signs. So let's do that now. And according to the ACLS algorithm, the ACLS drug that we're going to be administering is going to be atropine. Now, previously, atropine was 0.5 milligrams, and you can give a dose every 3 to 5 minutes with a maximum dose of 3 milligrams. However, if you're doing everything according to the new guidelines, which came out in 2020, you're now going to be given 1 milligram of atropine. And so in order for you to administer that drug, you're going to have a patent IV. And I would recommend having a patent IV that is more centrally located, such as in the left or the right in the cubital area. So once we have that IV inserted and we have a full set of vital signs, right now it looks like our patient's heart is compensating. The systolic blood pressure is greater than 90. So we're going to keep monitoring this, but we're going to start the IV at least and go ahead and hang some IV fluids in case we do need to infuse them later. With the SpO2 being 92%, I am going to go ahead and start some low flow oxygen, maybe about 2 liters, maybe 4 liters max via nasal cannula. And we're going to continue monitoring the respiratory rate. And again, if I didn't say so previously, our patient is afebrile. So after administering atropine 1 milligram, and we're going to administer it here at 1736, we don't treat monitors, we treat patients. We want to go back and reassess our patient. And I'm going to pause this really quickly and just try to show you the ACLS algorithm. All right, so the adult bradycardia algorithm, heart rate's typically less than 50 if it's a bradyarrhythmia. All right, and so we maintain the patent airway. Our patients right now on oxygen at 2 liters. We have the oxygen, a cardiac monitor. We've called for a 12 lead, and we want to consider the hypoxic or the toxicologic causes, and we talked about the digoxin or any other drugs that our patient could be using. This is a persistent bradyarrhythmia, and right now our patient does not have hypotension, but we are monitoring it. The level of consciousness, the person's alert, awake, and oriented by 3. There are no signs of shock. Patient is not complaining of any chest pain, and we don't have any acute signs of heart failure. And so if that is the case, if everything is no, we will monitor and observe. But of course, this wouldn't be a true bradycardia session if our patient didn't start deteriorating. All right, so we went ahead and we gave atropine. We gave atropine 1 milligram because over here it tells you what our dosages are. Atropine 1 milligram bolus. You can repeat every 3 to 5 minutes for a maximum dose of 3 milligrams. What I found in practice is that if atropine doesn't work, our patients usually don't, their blood pressure start decreasing. So you want to go ahead and be calling pharmacy to get the dopamine or the epinephrine IV infusion. Those sometimes are not on our floors and are not in our crash carts sometimes. So that may be something that you can actually hang later once it arrives, but you can go ahead and call for it. And now I'm going to go back to my rhythm. All right, so we gave atropine 1 milligram. There was no effect, but we don't treat monitors, we treat people. Let's go ahead and go back and reassess our patient. Our patient's now complaining of being very lightheaded. And when we recheck the blood pressure, our new blood pressure is 88/50. And so we can continue and just wait a few more minutes, but I don't like to see my patients in distress. And my goal is to prevent an arrest. So I can go ahead and draw up the next dose of atropine, but while I'm drawing it up, I'm also going to have my team members who are at the bedside go ahead and prepare the transcutaneous pace. And so over here, we have our transcutaneous pacemaker, which will be one of the functions that your manual defibrillator can do. If you've not been taught how to use a manual defibrillator in your ACLS class, your instructor should show you how to do so. But also on your floor, spend time with your charge nurse. Ask if you can shadow rapid response, because I think that you knowing how to run your codes is a part of you being a safe caregiver and a safe provider. And sometimes rapid response may not get to you in time, or you could be a traveling nurse and there may not be enough staff, enough well-trained staff. So you need to know what you're doing. All right, so when we have those pacemaker pads on, and of course we have our regular, our traditional 3 or 5 leads on also, I'm going to go ahead and I'm going to hit this pacer mode. All right, and so whenever I select the pacer mode, I have the rate set at 70, and I want you to look at something. Every time there's a pacer spike, to know that the machine is actually doing what it's supposed to do, we should see this wide and bizarre QRS complex, and we're not seeing this. So even though we have our monitor, our transcutaneous pacemaker set at 70, this patient's heart rate is still about 30. So I want to always remind you that you don't treat monitors, you treat patients. And so you want to go back and troubleshoot your TCP, your transcutaneous pacemaker. More than likely, the person may have a bigger chest, or they could be larger, and we're just not delivering enough energy. So down here, we have our milliamps. And again, if this is anything, if I'm telling you anything that contradicts what your facility or what your training guidelines have previously told you, I need you to go by what you've been taught, but this is what we use in our training environment. All right, so down here, we have our milliamps. I'm going to go ahead and resume it. We need to increase our milliamps until we have 100% capture. I want to see a QRS behind every pacer spike. Again, right now, our patient's heart rate is about 30 per minute, and that is too low to support, to support life. We don't want it going any lower. I'm going to increase my milliamps, and every time you increase your milliamps, your patient's feeling discomfort because that is more energy that they're going to be feeling. All right, and so right now your patient's probably saying ouch about 70 times per minute. But again, we don't treat this monitor, we treat patients. So you're going to go back and you're going to verify that the heart rate is actually 70. And now when you go back and you check the blood pressure and redo a set of vital signs, you should start seeing some improvement. Most patients do not like the transcutaneous pacemaker. It's not comfortable, but it is something that we can use in order to keep their heart rate up and improve their cardiac output until we can either get them to surgery for an internal pacemaker implantation, or until we can give them a digibind to reverse the effects of digoxin. But this would be what you would do, or how you would treat somebody who had symptomatic bradycardia. And then just to repeat this, let's reset. Let's change your heart rate to 30. All right, we're going to go through this one more time. All right, everybody, we're just going to repeat this one more time. We have a heart rate of 40. We're going to assess our patient. They are feeling symptoms such as dizziness. We're going to go ahead and get a full set of vital signs. O2 set at 94% is okay, but if you're like me, you just want to, go ahead and err on the side of caution, you may go ahead and put a nasal cannula on your patient. Our blood pressure is 92/50, which is extremely borderline, because we're supposed to treat whenever it's less than 90, and or if our patient has symptoms and our patient's already verbalized that they're dizzy. Our respiratory rate is 14. We're going to go ahead and start that IV, and we're going to start running some fluids. Based on the patient's history, we don't want to give too much fluid or give it too vigorously, because we don't want them to go into CHF. What drug would you be giving for someone who has symptomatic bradycardia with a heart rate of 40? If you said atropine 1 milligram, you're absolutely correct. Make sure they have a patent IV. If they don't have a patent IV, you want to be preparing to do an IO insertion that's intraosseous. And then, of course, for the O2 set, we put on 2 liters. So I'm going to go ahead and take that off of my monitor, which is an indication that we have addressed that. All right, and so after we give the atropine, if we do not have the desired effect, when we go back and reassess our patient, we want to be thinking about the secondary treatment. And for me, whenever I'm trying to prevent an arrest, my secondary treatment is going to be energy. It's going to take a while before those infusions come from the pharmacy. So I won't have dopamine or epi IV drip right now. My patient's heart rate is 78/50, and my goal is to prevent an arrest. So instead of going with another dose of epi, since epi didn't work the first time, I'm going to go ahead and go with my transcutaneous pacemaker function. Your defibrillator, your manual defibrillator, will have most of these same capabilities. You're going to apply the pads. Make sure the chest isn't too hairy. If it requires any conduction jelly or any ointment, you want to go ahead and put that on the patient's chest. And we're going to turn on our pacemaker. And now you want to troubleshoot your pacemaker, because we have set it at a rate of 70. However, we are not seeing a QRS complex, or which would, if we are feeling for the pulse, it would be a contraction. We're not seeing on the monitor a QRS complex after each pacer spikes. So we have a disassociation here. So we have failure to capture. The way that we fix that is by changing our milliamps, or the amount of energy that's going through the patient's chest wall. And this is when it becomes really uncomfortable for your patients. If you are considering any analgesics or sedation, I want you to always think about what that blood pressure is. We cannot give pain medications if the blood pressure will not tolerate it. All right, so we're going to go ahead and resume this. We're going to increase our milliamps, and I want you to follow whatever your manufacturer's guidelines are. And now, according to our monitor, we have 100% capture, but we do not. And the reason why I say 100% is because after each pacer spike, you have a QRS complex. And if you were to check the patient's apical or radial pulse right now, hopefully it's going to coincide with the heart rate. You should feel 70 pulsations per minute. And you should also start seeing an improvement in this blood pressure. Now you have bought yourself some time and your patient some time. They can now get to the cath lab in case or whatever procedure they need to go to, if they need an implanted pacemaker, or if you need to draw up some Digimine, if you have an order for that, if they're on digoxin and you have your dig levels, that will be something you can also consider right now. I hope this helped you understand the bradycardia station. If you have any questions, my name is Eunice Mathis with Florida Training Academy. Have a great day, everybody. Hello, everybody, and welcome. My name is Eunice Mathis. I'm a registered nurse, and I'm also the owner of Florida Training Academy. In today's video, we're going to just review quickly the SVT, the tachycardia station with the Acls algorithms. My goal is to make you more comfortable with running codes. Remember, if you can remember your drug and energy selections, that means that you're going to help improve patient safety. And don't be so reliant upon, the rapid response teams, because if they're with a sick patient who is critical, I need for you to be able to assist to handle your patient's emergency until those other advanced providers arrive. And so with the SVT algorithm, which I'll try to have over here on the other side of the screen, you have to know what SVT is. And then you have PSVT, which could be heart rates greater than 200. With the American Heart Association, you want to treat anytime someone has symptoms. So symptoms could include chest pain, palpitations, low blood pressure. If the systolic blood pressure is less than 90, we're going to have to, treat, and we may stop using medications at that point and think of what we really need to use in order to stop or decrease the chances of this person going into an arrest state. So if you find that medications aren't working, but the blood pressures are still decreasing, let's go ahead and use that energy. And so for this particular scenario, which I've not read for you, it's just showing you the monitor, and we're going to run through this as quickly. We have a patient whose heart rate is 200. It's a narrow complex, and our temperature is 98.3. As soon as you see this on a monitor, you already want to be getting your team involved. And so when your team comes to the room, even though we may not need a compressor, we may not need someone to manage the airway, you at least want to be thinking of that, because if we don't get this heart rate under control, our patient could go into cardiac arrest. And so if you have your CNA at the bedside, what role, what task would you delegate to a CNA or a patient care tech? And if you said vital signs and to go get that crash cart, you're absolutely correct. So here, let's get some vital signs on the monitor. All right, and so I'm going to pause it just so we don't have to speak past beeps. Right now we have a heart rate of 200. Our temperature is 98.3. Our patient's current blood pressure is 108/60, which means he or she is still compensating. Our O2 sat is 92%. Our respiratory rate is 28. Respiratory rate is 28. And for video purposes, I'm teaching in silos, but in the real world, we'll be doing multiple tasks, multiple assessments at once. And so we have this basic information. While the CNA is getting this, I need you to be doing a brief and focused assessment on your patient. That assessment will include what symptoms are they having. If the heart rate is 200, more than likely they're feeling palpitations. They may feel some anxiety, shortness of breath. Look at the O2 sat being 92%. And if the blood pressure continues to decrease due to the low cardiac output, the heart's beating way too fast for there to be a sufficient amount of blood flow. And don't forget that the oxygen is carried in the blood. So if the heart's beating so fast, eventually this patient's going to be dizzy. So this patient's automatically a fall risk. Get them in the bed and be prepared for an IV. If this person does not have an IV already infusing, you want to go ahead and be thinking about that. Right now, you may have it at just KVO or about 20 mLs per hour, just to make sure we have a patent IV. But if this person's SVT or if their symptoms continue out after using the vagal maneuver, we know that we're going to have to give a medication. So I'm going to go ahead and resume this. We have our current vital signs. We have as many team members at the bedside as we need, and you can call out multiple orders at once. For a heart rate of 220 in a patient who is compensating, you can ask the person to vagal. And so we're going to say at 1342, vagal maneuvers were attempted and they were not effective. You ask the patient to bear down, and he or she did so without any effect on the heart rate. We do not want this person's blood pressure dropping much lower. So if we have a patent IV, what medication, according to the Acls algorithm, would we give if a person has symptoms or if they have unstable tachycardia? And so the medication we'd be given would be adenosine if it's a narrow complex tachycardia. How many milligrams would you administer? If you said 6 milligrams, you're absolutely correct. Now, I need for you to educate the person who's going to be pushing the medication as well as educating the patient. And so if you remember anything about adenosine, you know that it has a short half-life. So you have to push it fast, followed by a fast flush. If you just push it fast and don't flush behind it, the medication is going to stay in the IV. So we want to make sure we push fast, followed by a fast flush, because this medication has a short half-life. And since it does have a short half-life, meaning that by the time the medication gets to the heart or reaches the heart, it may be ineffective, you want to make sure that your patient has an IV that's more central, maybe in the left antecubital, as opposed to using an IV that could be in the right hand. So make sure your patient has a patent IV that is large bore. Now, let's talk about what education we need to be giving to the patient. Because if we're pushing adenosine, a medication that's going to slow his or her heart rhythm, you may want to let your patient know that they're going to be feeling some, it could be possible that they feel nauseated, that they could feel some flushness, maybe a little bit of chest discomfort, but you want to be there, hold your patient's hand and let them know that you're going to be right there with them and that you've given this medication before. You have a full team around you to support you. And of course, if anything goes wrong, you would be right there. Always have the crash cart there if you're pushing adenosine. So we have our adenosine 6 milligrams that we have given, our O2 sat 92%. I'm borderline on this right now. I'm going to go ahead and put maybe a nasal cannula on about 2 or 4 liters. And if the O2 sat decreases any further, that's when I'll switch to a non-rebreather. But the goal would be to maintain that O2 sat above 94%. Right now, the cardiac output is low. Once the cardiac output improves, then the O2 sat will improve also. All right, so we're going to be pushing the adenosine, followed by a fast flush at 1344. We've educated our patient. We made sure we had an IV in the left antecubital area. And now that the atropine has been given, what do? If you're just staring at the monitor, we want to make sure that you actually treat your patients. We treat patients, not monitors. So once you give that medication, you want to go back and reassess your patient. All right. And so we said when we give adenosine, sometimes the heart rate could slow. For our classroom purposes, we did not show the slow heart rate, but usually it'll slow down drastically. And if it works, the heart rate will normalize. In our case, it did not work. And so I want you to go back and reassess your patient. You're going to do that focused assessment again. Check on level of consciousness and also repeat a blood pressure. At this point, our blood pressure is starting to lower, even with saline infusing. If you're going to give a bolus of fluid, I want you to be monitoring for fluid overload. Whenever you think of fluid overload, immediately a lot of caregivers think about dependent edema, the leg swelling. Well, that is late stage. If this person has a history of congestive heart failure or maybe pneumonia, you want to be making sure you listen to those lung sounds because if we give too much fluid too rapidly, we'll be fixing one problem and causing another. And so make sure you listen to the lung sounds. You can also look for jugular vein distension. Those are usually like the early stages, and that pedal edema would be late stage. All right, and so now we have our O2 at 4 liters. Our O2 sat is 94%, which is why I hit it. Our patient's still awake, alert, talking to us. However, the heart rate is now decreased. The blood pressure is now decreased, and the SBP is now 98. What is your next treatment? We've tried vagal maneuvers. We've given adenosine 6 milligrams, followed by a rapid flush. What will be the next treatment based upon this patient's blood pressure? And yes, we've also sought expert consultation, but it's going to take a few minutes for that cardiologist to arrive or for the cath lab to be prepared for an ablation. So I need you to manage this on your floor until the other experts are ready. If you say I give adenosine 12 milligrams, you're absolutely correct. All right, what education do you want to provide to this patient who's awake and alert and talking to you? What education do you want to provide to the nurse who's pushing the medication? And so now we're going to say that we gave adenosine 12 milligrams at 1347, but we don't treat patients, we don't treat monitors, we treat patients. So as soon as you give that medication, you go back and reassess your patient. And if you don't have your blood pressure cuff set for about every 2 to 3 minutes, you want to go ahead and repeat it now and get a new blood pressure reading. And our O2 sat is still 94% on 4 liters of oxygen via nasal cannula. All right, so now our heart rate is our blood pressure is 78/40. So vagal maneuvers did not work. The adenosine also did not work. We need to prevent an arrest. Because the blood pressure systolic is less than 90, we need to be thinking of other interventions besides medication. And so what I want you to, and if you think about some of the drips, the maintenance drips, those will take a while to come from pharmacy. So I need for you to use what's in your crash cart right now. And if the adenosine didn't work, what's on top of your crash cart is a device, your defibrillator, the manual defibrillator that also has a sync mode. Whenever you sync, we're going to be using energy to fix an electrical disturbance. Right now, too many parts of the heart are just firing, which is why the person has this rapid heart rate. Whenever you use the synchronized cardioversion mode, you'll know that the energy selection would be synced to the tip of the QRS complex. In other words, that's where the shock will be given, at the tip of the QRS complex versus on the S or the T wave. If you deliver energy and you're trying to synchronize cardiovert someone, but you forget to press the sync button, instead you can actually deliver the energy on the S or the T wave and cause that person to go into a lethal arrhythmia. And so we're not trying to do that. We're going to go ahead and activate our sync mode. The American Heart Association has gotten away from telling you how many joules to use for synchronized cardioversion. The old rule of thumb was if it was a narrow complex SVT, we would use 120 joules. However, they now want you to refer to your manufacturer's guidelines. So if I'm saying anything that your company or that the manufacturer's guideline for your defibrillator, if they don't say what I'm saying, I need for you to go by what they say. And so I'm going to increase my joules to 120. Narrow complex SVT. Remember, this patient is awake. We have fluids infusing for this blood pressure, but the blood pressure is going to continue to decrease as long as we have low cardiac output because the heart rate's so high. All right, so everybody's at the bedside. We're charging. What do we want our team members to do? All right, we're going to clear. Everybody's clear. 1, 2, 3, shocking on 3. 1, 2, 3, shock. We don't treat monitors, we treat people. Okay, so after this shock, this right here line is not a good line, but for classroom purposes, you're going to see that the heart rate picks right back up again, just so that we can go ahead and retreat this patient. All right, so great job, everybody. We delivered one synchronized cardioversion attempt at 120 joules, and now it looks like our heart rate has normalized. I can see P, QRS, I can see all my complexes. However, we don't treat monitors, we treat patients. What information do I need to be seeing on this screen, and what questions would you be asking the patient? All right, so as far as the screen is concerned, if you said you want to see a full set of vital signs, you're absolutely correct. Great job. And now our focused assessment, remember you'd have multiple people. Someone could actually be doing the vital signs while you're doing the focus history and the assessment on the patient. And so the questions would be the basics. Do you know where you are on a scale, pain level of 0 to 10? How bad is your pain right now? Because you did send 120 joules through this person's chest wall. So you do want to reassess and do a skin assessment. However, do not take those pads off right now, because just because we have stabilized the patient doesn't mean that our heart rate can't go back up again. All right, and so now you would get those orders, those maintenance orders from your physician. Hopefully the specialist will be coming soon, because American Heart Association will always say to seek expert consultation. But I just want to repeat, I want to go back through it. If you have a patient who has unstable SVT and their blood pressures can handle, if you have enough time, your first treatment is not a medication. Your first treatment will be vagal maneuvers. The second intervention would be the adenosine, 6 milligrams followed by 12 milligrams, based upon the person's blood pressure. If the blood pressure is still greater than 90 systolic, well, then you can give that second dose of adenosine. However, if the blood pressure is starting to decrease, or if your patient's having symptoms related to having a fast heart rate that are worsening, such as maybe some level of consciousness decrease, or some other changes, maybe they're having more chest pain, you probably want to go ahead and do the synchronized cardioversion. Remember, if you don't press that sync button, then of course we're just going to be shocking, on the S or the T wave, and we can cause a more lethal arrhythmia. Well, everybody, this is Eunice Mathis with Florida Training Academy. I hope this little brief tutorial assisted you to help you run an unstable tachycardia station during one of your upcoming ACLS classes, and hopefully it'll make you more comfortable if you have a patient who has a fast heart rhythm or a heartbeat in the real world. Have a great day, everybody. Hello, everybody, and welcome. My name is Eunice Mathis. I'm the owner of Florida Training Academy, and I'm also an American Heart Association Training Center faculty member for CPR, BLS, ACLS, and PALS. And in this video, we're going to be showing you how to manage a cardiac arrest. We're going to go ahead and pull up the algorithm. I love the circular algorithm. It just made ACLS and also the MegaCode so much easier for me. And so just give me one moment. I will pull that up for you now. All right, so everybody, this is the circular algorithm for adult cardiac arrest. And this blue circle represents 2 minutes of continuous CPR. And if you don't recall, every 2 minutes, your compressor should be switching out. This initial point, this is where we do our initial assessment. All right, and so this is when we come in and we actually do our assessment on our patient. It's our BLS assessment. We're checking for breathing and also for a pulse. And so if the person's not breathing, they don't have a pulse, you're going to go ahead and start CPR and call for your team and the AED. Whenever your team members arrive, they're going to be using a back mask device in order to provide breaths. It's going to be 30 compressions followed by 2 breaths, and they're going to switch out every 2 minutes. If the person is intubated or if they have a trach, it will be continuous CPR for 2 minutes, and then someone will be given a breath on an adult every 6 seconds. But for this particular scenario, we're just going to assume that our patient is not intubated. All right, so we've recognized that our person has they're in a cardiac arrest rhythm. And so we have two different rhythms or 2 different paths. And one is going to be shockable or non-shockable. And in a few moments, I'll go back to the actual rhythm that we have there. But if you have a shockable rhythm, you do your assessment, start CPR immediately, go ahead and charge your defibrillator. And so let's say we start off over here. It says for biphasic, our energy selection is going to be 100 up to 200 joules. So you can start off with as little as 120 joules, but while it's charging, we still want our compressors to be compressing. So then we're going to have everybody clear. And once the shock has been delivered, we're going to continue CPR. And so this would be 30 to 2. If we do not have an IV access on this first cycle, this is the time to start the IV. Okay, so first cycle is CPR, shock, IV. At the end of our first cycle, every 2 minutes, our compressor is going to switch. If you would like, you could pre-charge the defibrillator, but here's where we do our switch and our rhythm check to reconfirm whether or not our patient is still in a shockable or a non-shockable rhythm, or maybe they've achieved ROSC. So here we do our rhythm check. We realize our patient's still in pulseless VTAC. We do this within 10 seconds. We get back on that chest, 30 compressions followed by 2 breaths. And while the machine is charging, we're going to continue doing chest compressions. We'll clear before the shock is delivered, and then we will resume CPR immediately afterwards. you can go ahead and give your first medication now. And according to the circular algorithm, our first medication is going to be epi. And if you do not remember the dose, it is over here. It's going to be epinephrine IV or IO, 1 milligram every 3 to 5 minutes. And so a good rule of thumb is just to do epi every other cycle. And it doesn't have a max. So you can keep doing this until the provider or the physician calls a code or until the patient achieves ROSC. At the end of 2 minutes, we've been doing CPR, 30 compressions followed by 2 breaths. At the end of 2 minutes, what does your compressor do? Yes, they switch out. We have 10 seconds to do our rhythm check and our reassessment. We're also checking the defibrillator and also the monitor to see what our rhythm is. If the person continues to be in a shockable rhythm, we get back on that chest after 10 seconds. So while the machine is charging, we're going to keep doing compressions. Once the machine has charged, everyone's going to stand clear. The shock will be delivered. We resume CPR, and during this cycle, we'd be giving another medication. Now we're going to give our antiarrhythmic, and that is going to be amiodarone. And if you do not remember the dose, just think of the higher dose as the dead man dose. And I hate to say it like that, but for amiodarone, your first dose is going to be the higher dose, 300 milligrams. And now we continue. We repeat this cycle. 10 seconds, we do our check. If it's a shockable rhythm, hands on that chest until it's time to deliver the charge. And whenever we deliver that shock, everyone's clear. We resume CPR. And our next medication, we go back to epi. So it goes back and forth. Epi, amio, epi, amio. And if you recall, your second dose of amiodarone is 150 milligrams, or alternately, you can also use lidocaine for the first dose of amiodarone only. And so for most of us as nurses, most of our codes are going to last for about 10 to 15 minutes. And there is another course that's called ACLS EP. Those are like for the emergency room physicians, and they may have additional drugs that are not listed here, but this is all that we're covering. And so if you have been giving epi, amio, you've been running this code now for close to 10 minutes. At some point, you want to consider an advanced airway. And a good rule of thumb is that if you're getting adequate chest rise and fall with the back mask device, to not stop your compressions in order to, intubate, because that means you'd be taking your hands off the chest for longer than 10 seconds, unless you think the cause is truly respiratory. We need to get to those H's and T's, those reversible causes. And down here at the bottom of this box, it talks about the hypovolemia, hypoxia, hydrogen ions, hypo and hyperkalemia, and also hypothermia. And then for your T's, you have tension pneumothorax, you have tamponade as in cardiac, toxins, thrombosis, pulmonary, and coronary. And so by the time you get down here, like I said, we've been running this code for a few minutes, and it may be a good time to call the family members into the room to see if we should be continuing these efforts. If we're not seeing any response, or the patient already has a lot of comorbidities, sometimes your providers will go ahead and pronounce death. And that's when we will stop our efforts. So now I'm going to go back to our rhythm over here, and let's run our code. Let's see how much you remember. All right, so I see this on the monitor, but I don't treat monitors, I treat people. So I'm going to go ahead and do my BLS assessment, my BLS survey. I'm going to check for breathing and check for a pulse. Well, I'll make sure my scene is safe, and then check for responsiveness. There's no responsiveness, check breathing, check a pulse. In less than 10 seconds, I'm going to call my team, and I'm going to go ahead and start high quality chest compressions. And by myself, so I may do hands only CPR until the team arrives. Once the team arrives, hopefully we have enough caregivers to where we can start delegating roles. And so those roles would be the role of compressor number 1, compressor number 2, someone maintaining the airway. We have our recorder, we have our IV and med person, and we also need someone to work the equipment, such as the defibrillator, and maybe the team lead can do that. And so as the team lead, I'm going to go ahead and switch out. Someone else is going to go ahead and take over compressions. And so I feel that we have a shockable rhythm. This is pulseless VTAC. And so I'm going to go over here. Compressions are in progress, and I'm going to select my energy. If you remember from the circular algorithm, we can start off with 120 joules if we have a biphasic defibrillator, and that we do. Compressions are still in place. All right, so compressors, I need everyone to take their hands off. I'm going to go ahead and shock on 3. 1, 2, 3. Everyone's clear. Shock delivered. We resume CPR immediately. And so the recorder would document that at 20:04, 120 joules was delivered. And now if we don't have an IV, this is the time to get an IV. So your first cycle, your first 2 minutes consists of CPR, a shock, and IV. At the end of 2 minutes, what do your compressor needs to do? Your compressor is going to switch out, and then we have 10 seconds to reassess. And whenever we reassess, we're going to be reassessing during our BLS assessment all over again. We're checking a pulse. We're checking for breathing. If there is no pulse and there is no breathing, we can go ahead and start pre-charging that defibrillator if necessary. And now we're going to go ahead and resume our CPR within 10 seconds. And now you as the team lead can decide if you want to stack, if you want to go up on your energy. But remember, your maximum amount of joules that you can deliver for a biphasic defibrillator was 200 joules. So I'm going to go ahead and go up to 150. Everybody's clear? Actually, you can keep doing your CPR while it's charging. All right, and now everyone stand clear. Delivering on 3. 1, 2, 3. Shock delivered. Resume CPR. And if you remember from your circular algorithm, we had an IV in the first cycle. What drug do we give in the second cycle? It's the first ACLS drug. If you said epinephrine 1 milligram, you're absolutely correct. And so if you're not compressing, the epi is just going to sit in the arm. So we need someone doing some good high quality BLS compressions. That means you're compressing at least 2 inches for an adult at a rate of 100 up to 120 compressions per minute. And you are minimizing your interruptions to no more than 10 seconds. All right, so CPR has been in progress now. We're at the end of our 2-minute cycle. Our compressors are going to switch off. We're going to reassess again within less than 10 seconds. We can pre-charge the defibrillator if you can. All right, and so now we realize our patient's still in pulseless VTAC. We're going to go ahead and get back on that chest. 30 to 2, compressor is switched off. We're going to go ahead and use the same energy. The team lead can decide how many joules to use. All right, I'll go up to 170. All right, everyone clear? 1, 2, 3, shocking on 3. 1, 2, 3, shock. Shock delivered. And so if our last drug was epi, what drug do we give during this third cycle? That's right, amiodarone, 300 milligrams. So amiodarone, go ahead and push that. And, if you want to, you can have the med person go ahead and draw up the next dose of epi that will be given in the next cycle. Now, if you saw this on your monitor at the end of 2 minutes, this was pulseless ventricular tachycardia, and this is ventricular fibrillation. The treatment is the same. Both of these will be shockable rhythms. And so whenever you resume your compressions and you charge your device, you'll just pick up on whatever cycle you were last on. So I think the last medication we gave was amiodarone. So during this upcoming cycle, we will be giving epinephrine again, 1 milligram. However, what if at the end of 2 minutes, this is the rhythm that you saw? We don't treat monitors, we treat patients. I need for you to check for a pulse. And so I want to make sure that I'll make sure I put on the video that this is pulseless. If you see a rhythm on the monitor, but you do not feel a pulse, we call that pulseless electrical activity, or PEA. And so that is a non-shockable rhythm. So if we've already given amiodarone and we've given epinephrine, the only thing we can do during this cycle is high quality CPR until it's time to give epi again, and also get to those H's and T's. And I hope you can remember a couple of those H's and T's. We'll give you a few minutes to think about them now. H's and T's. We have to try to reverse this arrest. There's your reversible causes down here at the very bottom. Let's resume our scenario. At the end of 2 minutes, this is what we see on the monitor. And now when we go to check a pulse, we do feel a pulse. So that means that the person has achieved ROSC, or return of spontaneous circulation. But ROSC is not the end of the cardiac arrest algorithm. You have to actually take care of the management after the arrest, and we call that post-cardiac arrest care. And so if you think about what you did to prevent an arrest, now I need you to prevent a re-arrest. And so you don't just want to ask if the person has a pulse. You also want to know if they're breathing. And if your patient is not breathing, you're going to ask for the respiratory therapist or whoever is managing the airway to go ahead and intubate the patient. And how you confirm whether or not the tube is placed properly. You need to auscultate, but just not auscultate anteriorly. You also need to listen to the axillary area and also posteriorly, because if you only hear lung sounds on the right axilla area, it probably means that you have your tube down too far. You want to just retract it, pull back just a few centimeters, and then do your reassessment again, and hopefully you hear lung sounds on both sides. All right, and so now we have a heart rate. We have a patient who's intubated. Is our patient a candidate for targeted temperature management? And if they are unresponsive, yes, they are. What temperature do we want to keep our patients in for how long? If you said 32 to 36 degrees for 24 hours, you're absolutely correct. And that is going to actually help preserve some of the brain function so that the person doesn't work too hard. If you try to put someone who is responsive and make them cold using a cooling blanket, they're going to shiver too much and it's going to negate the effects. And you also want to be mindful as to whether or not the person has had any type of coagulation issues. If they clot, we don't want to make them cold. All right, and so for some reason, I'm having a hard time entering my CO2 here, but now that the person is intubated, we can actually use our Untitled CO2. We have something to connect it to. And with ROS, we would expect that level to be, greater than 35. So 35 to 40 with ROS. And let's go ahead and get a repeat blood pressure. And let's see what our O2 sat is. Now the person's intubated. What specialist would you like to call? All right, and so if you think about it, we just did chest compressions on this person. So if we did chest compressions, we definitely are going to need an EKG because there could be some cardiac. We want to find out what caused them to go into arrest to begin with. In addition to the EKG, we need some serial enzymes. So, a cardiac study. Let's get a chest x-ray, an echocardiogram, whatever bedside studies we can get. I mentioned coagulation studies a few moments ago, and then your regular BMP, CBC, etc. So you want to go ahead and start calling those various departments unless you're in the ICU, and you'd be, of course, drawing your own labs in most places. And then once you get the chest x-ray, we have a patient who's intubated. So who's going to manage the vent? In some places, they have an intensivist who does like this, all-inclusive care. In other places, you're going to have your cardiologist and you're going to have your pulmonologist. But your pulmonologist is going to order things such as your arterial blood gases, your continuous pulse oximetry, any weaning parameters, and any maybe like something to see if they have a blood clot in their lungs. So this is the basics of the circular algorithm. I'm going to go back to it one more time. All right. And so you want to try to prevent a rearrest, so continue to monitor your patient. And, I know that you all do such a great job taking care of our patients and our residents. And I hope that this assisted you and it's going to help you run your cardiac arrest station whenever you do have your ACLS class.
ACLS practice test with answers. Number 1. Which of the following statements about the use of magnesium in cardiac arrest is most accurate? A. Magnesium is indicated for shock-refractory monomorphic ventricular tachycardia. B. Magnesium is indicated for ventricular fibrillation and pulseless ventricular tachycardia associated with torsades de pointes. C. Magnesium is contraindicated for ventricular tachycardia associated with a normal QT interval. The correct answer is B. Magnesium is indicated for ventricular fibrillation and pulseless ventricular tachycardia associated with torsades de pointes. Number 2. A patient with ST segment elevation myocardial infarction has ongoing chest discomfort. Fibrinolytic therapy has been ordered. Heparin 4,000 units IV bolus was administered, and a heparin infusion of 1,000 units per hour is being administered. Aspirin was not taken by the patient because he had a history of gastritis treated 5 years ago. Your next action is to A. Give aspirin 160 to 325 mg chewed immediately. B. Give 75 mg enteric-coated aspirin orally. C. Give 325 mg enteric-coated aspirin rectally. D. substitute clopidogrel 300 mg loading dose. The correct answer is A. Give aspirin 160 to 325 mg chewed immediately because the patient does not have a recent diagnosis of gastritis. Number 3. A patient has sinus bradycardia with a heart rate of 36 beats per minute. Atropine has been administered to a total of 3 mg. A transcutaneous pacemaker has failed to capture. The patient is confused, and her systolic blood pressure is 110. Which of the following is now indicated? A. Give additional 1 mg of atropine. B. Start a dopamine drip at 10 to 20 micrograms per kilogram per minute. C. Start a normal saline bolus. D. Start an epinephrine drip at 2 to 10 micrograms per minute. The correct answer is D. Start an epinephrine infusion at 2 to 10 micrograms per minute. Epinephrine infusion may be used for patients with symptomatic bradycardia or hypotension after atropine or pacing fails. Number 4. A 62-year-old man suddenly experienced difficulty speaking and left side weakness. He was brought to the emergency department. He meets initial criteria for fibrinolytic therapy, and a CT scan of the brain is ordered. What are the guidelines for antiplatelet and fibrinolytic therapy? A. Do not give aspirin for at least 24 hours if tissue plasminogen activator is administered. B. Give aspirin 160 mg and clopidogrel 75 mg orally. C. Administer heparin if CT scan is negative for hemorrhage. D. Administer aspirin 160 to 325 mg chewed immediately. The correct answer is A. Do not give aspirin for at least 24 hours if tissue plasminogen activator is administered. There is a significant increase in the risk of symptomatic intracranial hemorrhaging if both of tissue plasminogen activator and aspirin are administered. Number 5. A patient with a possible ST segment elevation myocardial infarction has ongoing chest discomfort. Which of the following would be a contraindication to the administration of nitrates? A. Heart rate of 90 beats per minute. B. Left ventricular infarct with bilateral rails. C. Systolic blood pressure greater than 180. D. Use of a phosphodiesterase inhibitor within 12 hours. The correct answer is D. Use of a phosphodiesterase inhibitor within 12 hours. Nitrates are medications prescribed to treat heart attacks, chest pain, and some types of heart disease. Viagra, a phosphodiesterase inhibitor, also lowers blood pressure. Combining the two medications can result in a dangerously low or even fatal blood pressure. Number 6. A patient is in cardiac arrest. Ventricular fibrillation has been refractory to a second shock. Of the following, which drug and dose should be administered first? A. Epinephrine 1 mg. B. Vasopressin 20 units. C. Sodium bicarbonate 50 milliequivalents. D. Atropine 1 mg. The correct answer is A. Administer 1 mg of epinephrine via the intravenous or intraosseous route. Epinephrine is a commonly administered vasopressor in cardiac arrests. Number 7. A 35-year-old woman has palpitations, lightheadedness, and a stable tachycardia. The monitor shows a regular narrow complex tachycardia at a rate of 180 per minute. Vagal maneuvers have not been effective in terminating the rhythm. An IV has been established. What drug should be administered? A. Lidocaine 1 mg per kilogram. B. Adenosine 6 mg. C. Epinephrine 2 to 10 microgram per kilogram per minute. D. Atropine 0.5 mg. The correct answer is B. Administer adenosine 6 mg. Adenosine restores normal rhythm in paroxysmal supraventricular tachycardia by acting on the adenosine receptors in the atrioventricular node, slowing down the impulse conduction time and interrupting abnormal reentry pathways of electrical impulses in the AV node. Number 8. A patient with sinus bradycardia and heart rate of 42 has diaphoresis and a systolic blood pressure of 80. What is the initial dose of atropine based on the correct ACLS guidelines? A. 0.1 mg. B. 3 mg. C. 1 mg. D. 0.5 mg. The correct answer is C. Based on the 2020 American Heart Association guidelines, if the patient is presenting with hypotension, acute altered mental status, signs of shock, ischemic chest discomfort or signs of acute heart failure, Administer atropine at the dose of 1 mg every 3 to 5 minutes. Do not administer more than 3 mg total. Number 9. A patient is in refractory ventricular fibrillation and has received multiple appropriate defibrillation shocks, epinephrine 1 mg IV twice, and an initial dose of 300 mg amiodarone IV. The patient is intubated. A second dose of amiodarone is now called for. The recommended second dose of amiodarone is A. An endotracheal dose of 2 to 4 mg per kilogram. B. 300 mg IV push. C. 1 mg per kilogram IV push. D. An infusion of 1 to 2 mg per minute. E. 150 mg IV push. The correct answer is E. The second dose of amiodarone is 150 mg. Refer to the cardiac arrest algorithm for more information. Number 10. A patient with a possible acute coronary syndrome has ongoing chest discomfort unresponsive to 3 sublingual nitroglycerin tablets. There are no contraindications, and 4 mg of morphine sulfate was administered. Shortly afterward, the systolic blood pressure falls to 88, and the patient has increased chest discomfort. You should A. Give 250 to 500 milliliters of normal saline. B. Give an additional 2 mg of morphine sulfate. C. Give sublingual nitroglycerin. D. Start a dopamine at 2 microgram per kilogram per minute and titrate to a systolic blood pressure reading above 100. The correct answer is A. In this scenario, the patient's hypotension is caused by the use of nitrates and morphine. The best response is to start a normal saline fluid bolus. Monitor for signs of fluid overload. Number 11. A patient has a rapid irregular wide complex tachycardia. The ventricular rate is 138 per minute. The patient is asymptomatic with a systolic blood pressure of 110. He has a history of angina. Which of the following actions is recommended? A. Giving adenosine 6 mg IV bolus. B. Seeking expert consultation. C. Giving lidocaine 1 to 1.5 mg IV bolus. D. Immediate synchronized cardioversion. The correct answer is B. The patient is asymptomatic with a normal systolic blood pressure. Therefore, seek expert consultation and continue to monitor the patient. Number 12. You arrive on the scene with the code team. High-quality CPR is in progress. An AED has previously advised, no shock indicated. A rhythm check now finds asystole. After resuming high-quality compressions, your next action is to A. Gain IV or IO access. B. Place an esophageal tracheal tube or laryngeal mask airway. C. Attempt endotracheal intubation with minimal interruptions in CPR. D. Call for a pulse check. The correct answer is A. Gain intravenous or intraosseous access so that epinephrine can be administered. Number 13. A patient is in pulseless ventricular tachycardia. 2 shocks and 1 dose of epinephrine have been given. Which is the next drug dose to anticipate administering next? A. Amiodarone 300 mg. B. Amiodarone 150 mg. C. Vasopressin 40 units. D. Epinephrine 3 mg. E. Lidocaine 0.5 mg per kilogram. The correct answer is A. Ask the medication nurse to prepare 300 mg of amiodarone. Number 14. Your patient has been intubated. Intravenous access has been unsuccessfully attempted twice. Which of the following is also an acceptable route for drug administration during a code? A. Endotracheal. B. Oral. C. Intramuscular. D. Intraosseous. The correct answer is D. Intraosseous IO access is acceptable if IV access is not available. Endotracheal medication administration is no longer advised. Number 15. A patient is in cardiac arrest. Ventricular fibrillation has been refractory to an initial shock. What is the recommended route for drug administration during CPR? A. Femoral vein. B. IV or IO. C. Central line. D. Endotracheal. E. External jugular vein. The correct answer is B. Intravenous IV access is the preferred route of medication administration during Acls resuscitation. Intraosseous IO access is acceptable if IV access is not available. Number 16. A patient is in refractory ventricular fibrillation. High-quality CPR is in progress, and shocks have been given. 1 dose of epinephrine was given after the second shock. An antiarrhythmic drug was given immediately after the third shock. What drug should the team leader request to be prepared for administration next? A. Epinephrine 3 mg. B. Second dose of epinephrine 1 mg. C. Repeat the antiarrhythmic drug. D. Sodium bicarbonate 50 milliequivalents. The correct answer is B. Administer a second dose of epinephrine 1 mg. Refer to the cardiac arrest algorithm for more information. Number 17. A 57-year-old woman has palpitations, chest discomfort, and tachycardia. The monitor shows a regular wide complex tachycardia at a rate of 180 beats per minute. She becomes diaphoretic, and her blood pressure is 80/60. The next action is to A. Give amiodarone 300 mg IV push. B. Perform immediate synchronized cardioversion. C. Establish IV access. D. Obtain an electrocardiogram. The correct answer is B. In this scenario, the patient has symptomatic hypotension with a systolic blood pressure that is less than 90. Therefore, perform immediate electrical cardioversion in order to normalize the heart rate and improve cardiac output. Number 18. Bradycardia requires treatment when A. The systolic blood pressure is less than 100 with or without symptoms. B. The heart rate is less than 60 beats per minute with or without symptoms. C. The patient's 12-lead electrocardiogram show a myocardial infarction. D. Chest pain or shortness of breath is present. The correct answer is D. Chest pain or shortness of breath is present. Treatment for bradycardia, or a heart rate less than 50 beats per minute, depends on the severity of symptoms and the cause of the slow heart rate. If the patient does not have symptoms or if the systolic blood pressure is greater than 90, seek expert consultation and continue to monitor the patient. Number 19. Which of the following statements is the most accurate regarding the administration of vasopressin during cardiac arrest? A. Vasopressin can be administered twice during cardiac arrest. B. Vasopressin is indicated for ventricular fibrillation and pulseless ventricular tachycardia before delivery of the first shock. C. Vasopressin is no longer used to treat a cardiac arrest. D. Vasopressin is recommended instead of epinephrine for the treatment of asystole. The correct answer is C. According to the American Heart Association, vasopressin has been removed from the ACLS cardiac arrest algorithm. Vasopressin failed to demonstrate significant benefit compared with or in addition to epinephrine. Therefore, vasopressin is no longer used in the ACLS protocol. Number 20. A patient is in cardiac arrest. High-quality chest compressions are being given. The patient is intubated and an IV has been started. The rhythm is asystole. Which is the first drug dose to administer? A. Epinephrine 1 mg. B. Atropine 1 mg. C. Atropine 0.5 mg. D. Epinephrine 3 mg. The correct answer is A. The first drug to administer is epinephrine 1 mg IV or IO. Number 21. A 45-year-old woman with a history of palpitations develops lightheadedness and palpitations. She has received adenosine 6 mg for the rhythm shown above without conversion of the rhythm. She is now extremely apprehensive. Her blood pressure is 108/70. What is the next appropriate intervention? A. Repeat adenosine 3 mg IV. B. Perform immediate unsynchronized cardioversion. C. Sedate and perform synchronized cardioversion. D. Give adenosine 12 mg IV. The correct answer is D. Give adenosine 12 mg IV. Number 22. A patient in the emergency department develops recurrent chest discomfort suspicious for ischemia. Oxygen is being administered via a nasal device at 4 liters per minute, and an IV line is in place. The systolic blood pressure is 160. There are no allergies or contraindications to any medication. You would first order A. Sublingual nitroglycerin 0.4 mg. B. Morphine sulfate 2 to 4 mg IV. C. Lidocaine 1 mg per kilograms IV. D. Amiodarone 150 mg IV. The correct answer is A. Administer sublingual nitroglycerin 0.4 mg. Nitroglycerin is a sublingual tablet that's used to prevent and relieve chest pain related to angina. Number 23. Following initiation of CPR and one shock, ventricular fibrillation persists. A second shock is given and chest compressions are resumed immediately. An IV is in place and no drugs have been given. Bag mask ventilations are producing visible chest rise. What is your next order? A. Administer 3 sequential, stacked, shocks at 360 joules. B. Prepare to give amiodarone 300 mg IV. C. Administer 3 sequential, stacked, shocks at 200 joules. D. Prepare to give epinephrine 1 mg IV. The correct answer is D. Prepare to give epinephrine 1 mg IV. Number 24. You arrive on the scene to find a 56-year-old diabetic woman with dizziness. She is pale and diaphoretic. Her systolic blood pressure is 80. The cardiac monitor shows a bradyarrhythmia. The client is receiving oxygen at 4 liters per minute and an IV has been established. Your next order is A. Dopamine at 2 to 10 microgram per kilogram per minute. B. Sublingual nitroglycerin 0.4 mg. C. Morphine sulfate 4 mg IV. D. Atropine 1 mg IV. The correct answer is D. Order atropine 0.5 mg IV. Number 25. A patient becomes unresponsive. You are uncertain if a faint pulse is present with the rhythm below. What is your next action? A. Order transcutaneous pacing. B. Begin CPR, starting with high-quality chest compressions. C. Start an IV and give epinephrine 1 mg IV. D. Consider causes of pulseless electrical activity. The correct answer is B. Begin CPR, starting with high-quality chest compressions. If you are enjoying the video, please like the video and subscribe to our channel.
Pediatric Advanced Life Support Practice Exam with answers. Number 1. You are called to help resuscitate an infant with severe symptomatic bradycardia associated with respiratory distress. The bradycardia persists despite establishment of an effective airway, oxygenation, and ventilation. There is no heart block present. Which of the following is the first drug you should administer? A. Atropine. B. Dopamine. C. Adenosine. D. Epinephrine. The correct answer is D. Administer epinephrine for symptomatic bradycardia caused by respiratory distress in pediatric populations. Atropine should be administered if the primary cause of bradycardia is due to a suspected heart block, such as with adult populations. Number 2. Which of the following statements about the effects of epinephrine during attempted resuscitation is true? A. Epinephrine decreases peripheral vascular resistance and reduces myocardial afterload so that ventricular contractions are more effective. B. Epinephrine improves coronary artery perfusion pressure and stimulates spontaneous contractions when asystole is present. C. Epinephrine is contraindicated in ventricular fibrillation because it increases myocardial irritability. D. Epinephrine decreases myocardial oxygen consumption. The correct answer is B. Epinephrine improves coronary artery perfusion pressure and stimulates spontaneous contractions when asystole is present. Number 3. General assessment of a 2-year-old female reveals her to be alert with mild breathing difficulty during inspiration. On primary assessment, she makes high-pitched inspiratory sounds, mild stridor, when agitated. Her oxygen level is 92% on room air. Lung auscultation reveals transmitted upper airway sounds with adequate distal breath sounds bilaterally. Which of the following is the most appropriate initial therapy intervention for this child? A. Perform immediate endotracheal intubation. B. Administer an IV dose of dexamethasone. C. Nebulize 2.5 mg of albuterol. D. Administer humidified supplementary oxygen as tolerated and continue evaluation. The correct answer is D. Administer humidified supplementary oxygen as tolerated for suspected croup, mild stridor, and continue to evaluate. Number 4. Which of the following most reliably delivers a high concentration of inspired oxygen in a toddler or older child? A. Nasal device with 4 liters per minute of oxygen flow. B. Simple oxygen mask with 15 liter per minute of oxygen flow. C. Non-rebreathing face mask with 12 liters per minute of oxygen flow. D. Face tent with 15 liters per minute of oxygen flow. The correct answer is C. A non-rebreathing face mask with 10 or more liters per minute of oxygen flow delivers the highest concentration of inspired oxygen. Number 5. Which of the following statements about endotracheal drug administration is true? A. Endotracheal drug administration is the preferred route of drug administration during resuscitation because it results in predictable drug levels and drug effects. B. Endotracheal doses of resuscitation drugs in children have been well established and are supported by evidence from clinical trials. C. Intraosseous and endotracheal drug administration is just as effective as intravenous drug administration. D. Endotracheal drug administration is the least desirable route of administration because this route results in unpredictable drug levels and effects. The correct answer is D. Endotracheal drug administration is the least desirable route of administration because this route results in unpredictable drug levels and effects. Number 6. Which of the following statements most accurately reflects the PALS recommendations for the use of magnesium sulfate in the treatment of cardiac arrest? A. Magnesium sulfate is indicated for ventricular fibrillation refractory to repeated shocks and amiodarone or lidocaine. B. Routine use of magnesium sulfate is indicated for shock refractory monomorphic ventricular tachycardia. C. Magnesium sulfate is indicated for torsades de pointes or suspected hypomagnesemia. D. Magnesium sulfate is contraindicated and should not be used. The correct answer is C. Magnesium sulfate is indicated for torsades de pointes, also referred to as polymorphic ventricular tachycardia, or suspected hypomagnesemia. Number 7. You enter a room to perform a general assessment of a previously stable 10-year-old male and find him unresponsive and apneic. A code is called and bag mask ventilation is performed with 100% oxygen. The cardiac monitor shows a wide complex tachycardia. The boy has no detectable pulses. You deliver an unsynchronized shock with 2 joules per kilogram and resume immediate CPR beginning with compressions. A team member had established IO access, so you give a dose of epinephrine. At the next rhythm check, persistent ventricular fibrillation is present. You administer a 4 joules per kilogram shock and resume CPR. Based on the PALS pulseless arrest algorithm, what is the next drug to administer when CPR is restarted? A. Epinephrine. B. Atropine. C. Amiodarone. D. Magnesium sulfate. The correct answer is C. The next drug in the PALS cardiac arrest algorithm is amiodarone 5 mg per kilogram. Number 8. Parents of a 1-year-old female phoned the emergency response system when they picked up their daughter from the babysitter. Paramedics perform a general assessment revealing an obtunded infant with irregular breathing, bruises over the abdomen, abdominal distension, and cyanosis. Assisted bag mask ventilation with 100% oxygen is initiated. The heart rate is 36 per minute, peripheral pulses cannot be palpated, and central pulses are barely palpable. Chest compressions are started with a 15:2 compression to ventilation ratio. In the emergency department, the infant is intubated and ventilated with 100% oxygen, and IV access is established. The heart rate is now up to 150 beats minute, but there are weak central pulses and no distal pulses. Systolic blood pressure is 74. Of the following, which would be most useful in management of this infant? A. Epinephrine 0.01 mg per kilogram. B. Rapid bolus of 20 ml per kilogram of isotonic fluid. C. Atropine 0.02 mg per kilogram. D. synchronized cardioversion. The correct answer is B. Administer a rapid bolus of 20 ml per kilogram of isotonic fluid. Refer to the hypovolemic shock algorithm for additional information. Number 9. Which of the following statements about calcium is true? A. Routine administration of calcium is not indicated during cardiac arrest. B. The recommended dose is 1 to 2 mg per kilogram of calcium chloride. C. Calcium chloride 10% has the same bioavailability of elemental calcium as calcium gluconate in critically ill children. D. Indications for administration of calcium include hypercalcemia, hypokalemia, and hypomagnesemia. The correct answer is A. Routine administration of calcium is not indicated during cardiac arrest. Number 10. An infant with a history of vomiting and diarrhea arrives by ambulance. During your primary assessment, the infant responds only to painful stimulation. The upper airway is patent. The respiratory rate is 40 with good bilateral breath sounds, and 100% oxygen is being administered. The infant has cool extremities, weak pulses, and a capillary refill time of more than 5 seconds. The infant's systolic blood pressure is 85, and bedside glucose level is 30. Which of the following is the most appropriate treatment to provide for this infant? A. Establish IV access and administer 20 ml per kilogram of dextrose over 15 minutes. B. Establish IV access and administer 20 ml per kilogram of lactated Ringer's solution over 60 minutes. C. Establish IV access, administer 20 ml per kilogram of isotonic crystalloid over 10 to 20 minutes, and simultaneously administer 25% dextrose mixed in water at 2 to 4 ml per kilogram in a separate infusion. The correct answer is C. Establish IV access, administer 20 ml per kilogram of isotonic crystalloid over 10 to 20 minutes, and simultaneously administer 25% dextrose mixed in water at 2 to 4 ml per kilogram in a separate infusion. Reassess the blood sugar and monitor for signs of fluid overload. Number 11. General assessment of a 9-year-old male with increased work of breathing. Reveals the boy to be agitated and leaning forward on the bed with obvious respiratory distress. You administer 100% oxygen by non-rebreathing mask. The patient is speaking in short phrases and tells you that he has asthma but does not carry an inhaler. He has nasal flaring, severe suprasternal and intercostal retractions, and decreased air movement with prolonged expiratory time and wheezing. His oxygen level is 92% on a non-rebreathing mask. What is the next medical therapy to provide to this patient? A. Adenosine 0.1 mg per kilogram. B. Amiodarone 5 mg per kilogram. C. Albuterol by nebulization. D. Procainamide 15 mg per kilogram. The correct answer is C. Administer albuterol by nebulization. Number 12. An 8-month-old male is brought to the emergency department for evaluation of severe diarrhea and dehydration. In the ED, the child becomes unresponsive and pulseless. You shout for help and start CPR at a compression rate of 100 per minute and a compression to ventilation ratio of 30:2. Another provider arrives, at which point you switch to 2 rescuer CPR with a compression to ventilation ratio of 15:2. The cardiac monitor shows ventricular fibrillation. Of the following choices for management, which would be most appropriate to give next? A. Defibrillation 2 joules per kilogram. B. Normal saline 20 ml per kilogram IV rapidly. C. High-dose epinephrine, 0.1 mg per kilogram. D. Amiodarone 5 mg per kilogram. The correct answer is A. Administer a shock at 2 joules per kilogram. Number 13. General assessment of a 10-month-old male in the emergency department reveals a lethargic pale infant with slow respirations. You begin assisted ventilation with a bag mask device using 100% oxygen. On primary assessment, heart rate is 38, Central pulses are weak but distal pulses cannot be palpated. Systolic blood pressure is 60, and capillary refill is 4 seconds. During your assessment, a colleague places the child on a cardiac monitor, and you observe a bradycardic rhythm. The rhythm remains unchanged despite ventilation with 100% oxygen. What are your next management steps? A. Prepare for synchronized cardioversion. B. Start chest compressions. C. Start chest compressions and give epinephrine 0.01 mg per kilogram. D. Administer 20 ml per kilogram of isotonic crystalloid. The correct answer is C. If a pediatric patient continues to show signs of poor perfusion after oxygenation therapy and the heart rate decreases under 60 beats per minute, start chest compressions and give epinephrine 0.01 mg per kilogram IV or IO. Number 14. A 3-year-old unresponsive, apneic child is brought to the emergency department. Emergency personnel report that the child became unresponsive as they arrived at the hospital. The child is receiving CPR, including bag mask ventilation with 100% oxygen and chest compressions at a rate of 100 per minute. Compressions and ventilations are being coordinated at a ratio of 15:2. You confirm that apnea is present and that ventilation is producing bilateral breath sounds and chest expansion, while a colleague confirms absent pulses. Cardiac monitor shows ventricular tachycardia. A biphasic manual defibrillator is present. You quickly use the crown heel length of the child on a length-based, color-coded resuscitation tape to estimate the approximate weight as 15 kilograms. Which of the following therapies is most appropriate for this child at this time? A. Establish IV access and administer amiodarone 5 mg per kilogram. B. Establish IV access and administer lidocaine 1 mg per kilogram. C. Attempt defibrillation at 30 joules, then resume CPR beginning with chest compressions. D. Establish IV access and administer epinephrine 0.01 mg per kilogram. The correct answer is C. Shock or defibrillate at 30 joules, then resume CPR beginning with compressions. Number 15. General assessment of a 10-year-old male shows him to be unresponsive. You shout for help, check breathing, find he is apneic, and give 2 breaths. After finding that he is pulseless, you begin cycles of compressions and ventilations with a compression rate of 100 per minute and compression to ventilation ratio of 30:2. A colleague arrives and places the child on a cardiac monitor, revealing ventricular fibrillation. The two of you attempt defibrillation at 2 joules per kilogram and give 2 minutes of CPR. The rhythm persists at the second rhythm check, at which point you attempt defibrillation using 4 joules per kilogram. A third colleague establishes IO access and administers 1 dose of epinephrine 0.01 mg per kilogram during the compressions following the second shock. If the ventricular fibrillation persists after 2 minutes of CPR, what is the next drug dose to administer? A. Epinephrine 0.1 mg per kilogram. B. Adenosine 0.1 mg per kilogram. C. Amiodarone 5 mg per kilogram. D. Atropine 0.02 mg per kilogram. The correct answer is C. Amiodarone 5 mg per kilogram IV or IO is the next drug to be administered. Number 16. A 1-year-old male is brought to the emergency department for evaluation of poor feeding, fussiness, and sweating. On general assessment, he is lethargic but arousable and has labored breathing and a dusky color. Primary assessment reveals a respiratory rate of 68 breaths per minute. The heart rate is 300 per minute, systolic blood pressure is 70, capillary refill is 6 seconds, oxygen level is 85% in room air with good bilateral breath sounds. You administer high-flow oxygen and place the child on a cardiac monitor. You see a fast, narrow, complex rhythm with little beat-to-beat variability. Secondary assessment reveals no history of congenital heart disease. Intravenous access has been established. Which of the following therapies is most appropriate for this infant? A. Make an appointment with a pediatric cardiologist for later in the week. B. Adenosine 0.1 mg per kilogram IV rapidly. If adenosine is not immediately available, perform synchronized cardioversion. C. Perform immediate defibrillation without waiting for IV access. D. Establish IV access and administer a fluid bolus of 20 ml per kilogram of isotonic crystalloid. The correct answer is B. Administer adenosine 0.1 mg per kilogram IV rapidly. If adenosine is not immediately available, perform synchronized cardioversion. Refer to the PALS tachycardia with a pulse algorithm for additional information. Number 17. A child becomes unresponsive in the emergency department and is not breathing. You provide ventilation with 100% oxygen. You are uncertain if a faint pulse is present. What is your next action? A. Begin high-quality chest compressions with ventilations. B. Begin transcutaneous pacing. C. Start an IV and give atropine 0.01 mg per kilogram. D. Start an IV and give epinephrine 0.01 mg per kilogram. The correct answer is A. Begin high-quality chest compressions with ventilations. Number 18. You are preparing to use a manual defibrillator and paddles in the pediatric setting. When would it be most appropriate to use the smaller, pediatric-sized paddles for shock delivery? A. To attempt synchronized cardioversion but not defibrillation. B. If the patient weighs less than approximately 25 kg or is less than 8 years of age. C. If the patient weighs less than approximately 10 kg or is less than 1 year of age. D. Whenever you can compress the victim's chest using only the heel of one hand. The correct answer is C. If the patient weighs less than approximately 10 kg or is less than 1 year of age. Number 19. A 7-year-old boy is found unresponsive, apneic, and pulseless. CPR is ongoing. The child is intubated and vascular access is established. The heart monitor reveals an organized rhythm, but a pulse check reveals no palpable pulses. Effective ventilations and compressions are resumed, and an initial IV dose of epinephrine is administered. Which of the following therapies should you perform next? A. Attempt to identify and treat reversible causes, using the H's and T's as a memory aid. B. Attempt defibrillation at 4 joules per kilogram. C. Administer epinephrine 0.1 mg per kilogram. D. Administer synchronized cardioversion at 1 joules per kilogram. The correct answer is A. Attempt to identify and treat reversible causes, using the H's and T's as a memory aid. Number 20. You are evaluating an irritable 6-year-old girl with mottled color. On primary assessment, she is febrile with a temperature of 40 degrees Celsius or 104 degrees Fahrenheit. Her extremities are cold with a capillary refill of 5 seconds. Distal pulses are absent and central pulses are weak. Heart rate is 180 per minute, respiratory rate is 45 breaths per minute, and a systolic blood pressure is 98. Which of the following most accurately describes the categorization of this child's condition using the terminology taught in the PALS provider course? A. Hypotensive shock associated with inadequate tissue perfusion. B. Hypotensive shock associated with inadequate tissue perfusion and significant hypotension. C. Compensated shock requiring no intervention. D. Compensated shock associated with tachycardia and inadequate tissue perfusion. The correct answer is D. The systolic blood pressure is 98. Therefore, compensated shock associated with tachycardia and inadequate tissue perfusion is the best response. Number 21. An 8-year-old child was struck by a car. He arrives in the emergency department alert, anxious, and in respiratory distress. His cervical spine is immobilized, and he is receiving 100% oxygen by a non-rebreathing face mask. Primary assessment reveals a respiratory rate of 60 per minute, heart rate of 150, systolic blood pressure of 70, and an oxygen level of 84% on supplementary oxygen. Breath sounds are absent over the right chest, and the trachea is deviated to the left. He has weak central pulses and absent distal pulses. Which of the following is the most appropriate immediate intervention for this child? A. Perform endotracheal intubation and call for a stat chest X-ray. B. Provide bag mask ventilation and call for a stat chest X-ray. C. Establish IV access and administer a 20 ml per kilogram of normal saline fluid bolus. D. Perform needle decompression of the right chest and assist ventilation with a bag and mask if necessary. The correct answer is D. Perform needle decompression of the right chest and assist ventilation with a bag and mask if necessary. Number 22. An 18-month-old child presents with a 1-week history of cough and runny nose. You perform a general assessment, which reveals a toddler responsive only to painful stimulation with slow respirations and diffuse cyanosis. You begin a primary assessment and find that the child's respiratory rate has fallen from 65 breaths per minute to 10. Severe inspiratory intercostal retractions are present. The heart rate is 160, oxygen level is 65% on room air, and the capillary refill is less than 2 seconds. Which of the following is the most appropriate immediate treatment for this toddler? A. Establish vascular access and administer a 20 ml per kilogram bolus of isotonic crystalloid. B. Open the airway and provide positive pressure ventilation using 100% oxygen and a bag mask device. C. Administer 100% oxygen by face mask, establish vascular access, and obtain a stat chest X-ray. D. Administer 100% oxygen by face mask, obtain an arterial blood gas, and establish vascular access. The correct answer is B. Open the airway and provide positive pressure ventilation using 100% oxygen and a bag mask device. Deliver 1 breath every 2 to 3 seconds. Number 23. You are supervising another healthcare provider who is inserting an intraosseous needle into an infant's tibia. Which of the following signs should you tell the provider is the best indication of successful insertion of a needle into the bone marrow cavity? A. Pulsatile blood flow will be present in the needle hub. B. Fluids can be administered freely without local soft tissue swelling. C. You are unable to aspirate any blood through the needle. D. Once inserted, the needle shaft of the needle moves easily in all directions within the bone. The correct answer is B. Fluids can be administered freely without local soft tissue swelling. Number 24. A pale and obtunded 3-year-old child with a history of diarrhea is brought to the hospital. Primary assessment reveals a respiratory rate of 45 breaths per minute with good breath sounds bilaterally. Heart rate is 150 beats per minute, systolic blood pressure is 90, and the oxygen level is 92% in room air. Capillary refill is 5 seconds and peripheral pulses are weak. After placing the child on a non-rebreathing face mask with 100% oxygen and obtaining vascular access, which of the following is the most appropriate immediate treatment for this child? A. Obtain a chest X-ray. B. Begin a maintenance crystalloid infusion. C. Administer a bolus of 20 ml per kilogram of isotonic crystalloid. D. Administer a dopamine infusion at 2 to 5 microgram per kilogram per minute. The correct answer is C. Administer a bolus of 20 ml per kilogram of isotonic crystalloid and monitor for signs of fluid overload. Number 25. You have just assisted with the elective endotracheal intubation of a child with respiratory failure and a perfusing rhythm. Which of the following provides the most reliable, prompt assessment of correct endotracheal tube placement in this child? A. Absence of audible breath sounds over the abdomen during positive pressure ventilation. B. Auscultation of breath sounds over the lateral chest bilaterally plus presence of mist in the endotracheal tube. C. Confirmation of appropriate oxygen and carbon dioxide tensions on arterial blood gas analysis. D. Clinical assessment of adequate bilateral breath sounds and chest expansion. The correct answer is D. Clinical assessment of adequate bilateral breath sounds and chest expansion. End-tidal waveform capnography and a chest X-ray are also used to confirm correct endotracheal tube placement.
All right, everybody. Good morning, and welcome to Florida Training Academy. So you all are here for the CPR/BLS instructor course. My name is Eunice Mathis. I've been a nurse for 23 years. What I'm going to teach you is we just want to do a skills review before we even start the actual course, because that seems to be a knowledge deficit for a lot of instructors, especially if they're new or if they've not been in a hospital environment where they work as a team. And so with the CPR/BLS, just don't think of healthcare providers. Think of anyone who would work together as a unified front, rapid response. Sometimes whenever I'm teaching those who work in the marine industry, if there's an emergency out there on the ship, the Coast Guard may not get there for 30 minutes. They have to manage that emergency. And so that's what we're going to teach you. We're going to teach you individual CPR, but also how to work as a team. And we'll talk about the differences in the terms that I'm using, but it's important for you to understand those terms as future or current instructors, because when your students call and they ask for a CPR course, they don't know what they don't know. And what they don't know is if they just get a CPR card, but they're going to nursing school, that the school will not accept the card that they have. So we have a term called basic life support, and we have a term called CPR. What does CPR stand for, anyone? Cardiopulmonary Resuscitation. Awesome. Cardio, we're doing those chest compressions. Pulmonary, we're going to be providing rescue breaths. However, due to COVID, even prior to COVID, you didn't have to put your mouth on the victim's mouth, because back then we were worried about, contracting herpes or they may vomit. But now with COVID, there's not a facial device at this current time that's going to prevent COVID from crossing. And so you can do hands only, sustain life, circulate blood to the heart, the lungs, and the brain. You can do hands-only compressions until your team arrives. And when your team arrives, they're going to use the bag mask device. When you call 911, call EMS, they're not going to come there with a pocket mask and a facial shield to give a breath, because that's not going to protect them from contracting or passing COVID. So anyway, you can do hands-only CPR to help save a life. That's if you're teaching basic CPR. Basic CPR, you can incorporate breaths, but if not, you can wait for the EMS, for those professional rescuers to arrive. When you think of basic life support, I want you to think of when you watch a TV show like ER, and all those people around the bed and they're fussing, and this doctor knows more than that doctor, but we're supposed to actually communicate better than that, and they're doing all that for drama. Okay, so, and she's smiling. And so you want to be able to work as a team. What are some of the team roles, do you think? If you had the 5 of us and we were your team members, and there was someone in cardiac arrest, what do you think some of our, if you had to delegate tasks, what task would you delegate? You go get the AED device. Okay, the AED, awesome. What else? Automate chest compressions. Perfect. And if we had equipment to ventilate, you want to delegate someone to manage what task? The airway. And so I'm just going to repeat that. So she said the AED, or the electrical activity, and then we have our compressors, we have someone maintaining the airway. But when we start watching the basic life support videos, they're actually going to have a team of rescuers come, and some of those are advanced rescuers, such as doctors and nurses and respiratory therapists. So if you have additional team members, someone can start the IV, give medication, start the IV fluids, but it's going to be really important for you to know your role. And if you're not a doctor, a nurse, or a pharmacist, you can't give medications. You more than likely cannot start that IV. And some of us have on masks right now. Imagine full COVID season with us having on full PPE, and a doctor points to you and says, "Hey, I need you to intubate." You look like you can intubate. Can you intubate? Is that within your scope of practice? No. You want to let that doctor know that, "Hey, doc, I can't do XYZ, but this is what I can do based upon my certification or skill." You don't get to leave, because you are part of the team.
and you can do those chest compressions and you know how to work the defibrillator. So during our class today, we talked about CPR being cardiopulmonary resuscitation. When we get to pulmonary, at no point will you put your mouth on our equipment. We will only simulate breaths. When you teach your classes, it's what works best for your environment. If you know you're around a team that always works together, and if Mr. Johnson goes down, you're going to give Mr. Johnson mouth to mouth, well, then you may want to incorporate that in your classes. But when you watch the video discusses mouth to mouth, but we don't actually practice it. They will instead have you practice pocket masks, and we'll show you how to use that device also. So, CPR, do you have to provide rescue breaths? No. When in doubt, speak to your risk managers at your companies to see what's going to be the requirement. And when I go out and teach corporate classes, a lot of those risk managers are like, no, we're going to do hands-only CPR. We're going to use the AED. And when the emergency responders come, that is when they can use that bag mask device to give a breath. If you're in the hospital, then of course you already have that bag mask device there and it's on your crash card. What does the AED stand for, Andrea?
Automatic external defibrillator.
What does that device, what does it do to the heart's rhythm?
It sends an electrical signal through it to try to restart that from a arrhythmia. Try to stop it, start it, and put it into a normal rhythm.
Perfect. So to help you all pass the test, which we have today, we have two tests. The AED normalizes an abnormal heart rhythm. That's the goal. So you want that AED to get there as fast as possible. All right, so we talked about chest compressions, we talked about breaths, we talked about the AED. Do you know how fast we compress? How many compressions per minute?
100.
That's minimum. And what's the max? Help her out, team.
120.
120. All right, 100 to 120. And it's okay, we'll write notes again in a few moments. How deeply do you compress for an adult?
2 to 2.4.
2 to 2.4. You all today, you're taking care of a bariatric patient. The side view of their chest is this wide. Going 2 inches may not be as effective. So give me that fraction.
1/3.
1/3. You bring the side view of that chest in 1/3 of the way. Is it a possibility that we're going to crack ribs? Absolutely. It could happen. What law protects you if you're rendering aid? It's a biblical story. Good Samaritan law. And so as a CPR instructor, I really encourage you, if you're going to be teaching in different states, but you want to know the Good Samaritan law for that area. And so if you're taught basic life support, you're a basic life support instructor, and if you're teaching based upon those standards, the Good Samaritan law should protect you. However, if you decide to go in and create a little hole in someone's throat and make a tracheostomy, then of course it's not going to protect you. So as long as you're doing what you've been taught, you should be okay. Why are women more likely to die from sudden cardiac arrest? You know? You can't think of it. What about you, Andrea?
I would imagine that less people are likely to, like men,
Mm-hmm.
want to go out there and are afraid of being
Bring it out. You're on the right track.
breaking, being sued for.
You're absolutely correct.
They have breasts they don't like to do.
So if a woman were to suffer from sudden cardiac arrest, she is more likely, and this is outside of a hospital, she's more likely to be resuscitated if she's around men because of the breast factor. Yes. So it could be because they don't want to touch us because they think they're going to have a sexual assault case. But if you are a professional rescuer, you can still perform chest compressions on top of clothing. But why is it vital that you disrobe for the AED? So there may be a delay in someone starting CPR because they don't want to touch your breast. And then even once they touch your breast and they're calling 911, and 911 takes 5 minutes to get there, by the time someone finally cuts your clothing off and exposes your chest, it's been about 4 minutes before anyone ever used the AED on you. So women who sustain sudden cardiac arrest, I think their survival rate is 38% versus 43% if it's a male. And so when you're out there and you're teaching people, I need you to make sure you let them know about those statistics. And that if a male exposes a woman's chest, and she is in cardiac arrest and he knows CPR, He's supposed to do that, and he's protected by the Good Samaritan law. And if he still says no, because I teach a lot of people and they say, no, I'm not doing it. If they still say no, encourage them to provide CPR on top of clothing. And when a rescuer comes who feels comfortable taking off and exposing the breast, that is when we'll do that. All right, and so what questions do you all have before we start our practice? What does ROSC stand for? And so if that term is foreign to you, imagine a 17-year-old go-getter who's like, look, I'm about to be a CNA. I just want to get my BLS course so I can be a transporter in the hospital. And you start speaking terms like ROSC. I need you to take those medical terms and simplify them. We have to use the medical terms because the American Heart Association videos say those terms, but in layperson terms, the pulse returns. The person's alive. ROSC is return of spontaneous circulation. How long can you take your hands off of the chest? 10 seconds. And this is a little bit tricky for people to comprehend. The old school way, if someone was in cardiac arrest, we say ABC, ABC, ABC. What does ABC stand for? Yes, airway, breathing, circulation. And so when there's an emergency, we normally focus on airway, but cardiac arrest is a different emergency that requires a different response. Once someone no longer has a pulse, we're not focusing on their airway. Our new priority is CAB. What does CAB stand for? Just change those letters around. Yes, and so that's why you don't have to give a breath right now. So you can do hands-only CPR to circulate that blood. There's still some residual oxygen in the bloodstream. Your job is to circulate it. We're trying to preserve the brain, send blood to the brain. And whenever your team comes, that's when they can focus on the B and the C, the breathing. Sorry, the A and the B, the airway and the breathing. I said all that to ask the same question that I ask every class. If a victim in sudden cardiac arrest vomits and you're by yourself, what do? Chest compressions. If you turn them to their side to clear out their airway, what is happening to the blood flowing to their brain? It stops. Okay, so if you're by yourself, you will not turn your victim to their side to clear out their airway. You will have to keep doing your high quality chest compressions. You can try to sweep their mouth out within 10 seconds, but you get back on that chest and keep doing your compressions. And when your team comes, they have suction equipment, they can intubate, they can bag, but that is not your primary focus if you're a solo rescuer. Okay, you two are going to be teamed together. You two are going to be teamed together. So when I get you, when you stand, would you please come over here? All right. And when you stand, if you can come here. Andrea, when you stand, you all can stand now. Would you come here? And then Shilling down, when you stand, if you'll come here. All right. So you're going to be at the head of the victim. I'll give you a bag, and you're going to be on this side over here. Okay. All right. And so I may have to turn this around just a little bit. Can I get you to stand right here? All right. Let me get you right here, Andrea. Okay. All right, because what I'm worried about is whenever you are practicing, and you have to know like the layout of your room and the layout of your equipment. When I purchased these tables, the more sturdier part is on the opposite side. So I kind of had you all stand the wrong way. I'll fix that in a few moments. So if you're purchasing equipment, you want to try to purchase equipment that maybe has four legs on the table. The reason why we use the tables is because we're used to training healthcare professionals where if there was an emergency, we'd normally be on the elevated surface, such as a bed. Okay, our beds go into CPR mode. Our patients would not necessarily be on the floor. However, if you're training people, depending on what audience you're training, some of your students have to go to the floor. Some of them can be on the elevated surface. Regardless, if we do have our patient, our simulated patient on the elevated surface, and our compressor cannot compress deeply enough to get those feedback devices to actually indicate, we're going to put that person to the floor. Right? So it'll make sense in a moment. So if I can get you to please locate, we're going to talk about the xiphoid process. It's at the very end of the breastbone. Do not compress on that. We talked about the fact that you could possibly break bones. That's not one that you want to break or lacerate because the liver sits beneath it and you could puncture the liver, right? So pretend the person has a perfect breast line or nipple line. Interlock your hands like so and press your hands right in the center. So I'm gonna shift you. Your hip should be aligned. Oh, you're moving too much. There we go. All right. And You may have to tippy toe, press straight down. Let's see you. And press straight down. All right, so we're going to put you on top of the medical bed today. Go ahead and tippy toe. Press straight down. All right, so may I please ask you to back away just for a moment? And it's going to look like this. I'm going to put my shoulders on top. Press straight down. Lock those elbows. There we go. All right, and so how many compressions do we do per cycle? 30, okay? And so what I will have you all do first is 30 compressions. Our feedback devices, which are required by the American Heart Association. When you press down deeply enough, you hear a click. When you press at the appropriate rate, you're going to see 2 green lights. If you see, and what happens is because this is kind of painful, you all will have this orange light flashing really fast. That means you're not allowing full chest recoil. You're going so fast because it hurts to keep doing this that you're not allowing the heart time to refill with blood. All right, so would you two please practice 30 compressions? Let's go. And count for me. 1, 2, a little bit too slow. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28. All right, keep going. 1, 2, 3, 4, 5, 6, 7, 8. Great job. Count with them, teammates. Keep going. 1, 2, 3, 4. You have 3 more cycles. Great job. 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 20. Keep going. 1, 2, 3, 4, 5, 6, 7, 8.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24.
Help is coming. Don't get tired. Let's go. One more cycle. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29.
Great job. You all have 10 seconds to switch. All right, let's switch out. All right, next compressors. Let's go. Let's go.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Great job. Don't go too fast, Andrea. 21, 22, 23, 24, 25, 26, 27, 28. 4 more cycles. Let's go. 1, 2, 3, 4. Whatever number you all are on. Let's start together. Let's pause. Let's get our numbers together. All right. Woo! And if your bottom hand is hurting, I would recommend you have your lower fingers extended out. You can switch hands. That's the end of our 10 seconds. Let's compress some more. Let's go. 1, 2. Everybody stay together. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Good job. 2 more cycles. You got this. 7, 28, 29, 30. 1, 2, 3, 4, 5. Lock those elbows. Press straight down.
9, 10, 11, 12,
Watch me.
13, 14,
Move your hand. Get all the way over. All the way over.
15.
There we go. 17, 18, 19, 20. You're almost done, Andrea. This is your last cycle. 26, 27, 28, 29, 30. Great job, everybody. All right. You're done. You're done.
Oh, I was like,
All
where are
right.
we going? I was like,
All right. So what we have guaranteed is that our instructors can actually compress on their mannequins. And so what happens, and I've seen this a lot, is that when nurses decide to retire, they're like, hey, I want to teach CPR. But if you can't do this, you can't teach CPR. And that means you also sometimes have to go to the ground with your students. But none of you all have to go to the ground because you all have actually compressed at the appropriate rate and depth on the actual simulated beds. And when you're with your team, of course, everybody will be on the floor.
Always on the floor.
Always on the floor. What are the feedback devices required by the American Heart Association?
Rate, recoil,
Okay.
and I guess depth.
Depth. So the recoil, and that's when you'll get that orange light if you don't let the chest rebound, go back to its normal position. But it's going to be the depth and you'll know you're going deep enough because you'll hear the click. And then for your rate control, you're going to have the lights in the shoulders. I recommend, and I'll send you all a link that has the equipment that you'll need. I recommend that you all purchase lots of rechargeable batteries. Don't even worry about traditional batteries. You want to be recharging these batteries. We just started labeling them. Like number 4 would always die. So we don't know what mannequin number 4 was doing in the middle of the night when we weren't here, but we charge those batteries, wake up the next day, and then, it'd be dead again. All right. So now if it's going to be team, so what happens is you actually do your assessment, and I'll do one right now. So we're going to look left and we're going to look right. We're going to make sure our scene is safe. Now, what do I do from there?
Check for response.
Hey, are you okay? Are you okay? And now old school would be you'll check for the pulse and breathing simultaneously before you ever call for help. That's old school. When I am tapping and shouting at someone, hey, are you okay? And they're not responding, I need help right then. What would be a reason that someone is unresponsive but still alive? Overdose. And opioid crisis. What else? Hypoxia. She's using those.
Sorry.
Okay, so yeah, so my baby over here. All right, she used the big terms, yes, but so they could have maybe they have low oxygen because they overdosed. What about a diabetic? Low blood glucose. So you don't need to crack their ribs. As soon as you tap and you shout, and that person's not responding to you, hey, you call 911 or come back. Or if you're in the hospital, you press your code button. Now you're going to check for breathing and a pulse simultaneously. What is the name of the pulse that we check? Carotid. Okay, so usually we're not feeling for the radial pulse, the pulse that's in the wrist, and you're going to feel for the carotid pulse and check for breathing for less than 10 seconds. 9, 8, 7, 6. Person lets out a gasp, but there is no pulse and no other signs of life. We call that an agonal breath. An agonal breath is a precursor to death. You still start CPR. Okay. So 10 seconds, there's no pulse, there's no breathing. Hey, you call 911, bring me that AED. When your team comes, so you're going to do exactly what you did. You're going to do compression only CPR until your team arrives. For our demo right now, when your team arrives, they're going to come with the bag mask device. Andrea, let's let Andrea go first. All right. So, all right, I need everyone to practice. So your airway person, think a respiratory therapist. And so if you two would just watch them for now, it's going to be the EC clamp technique. And our mannequins have been difficult lately. EC clamp technique, open up the airway and give a breath. 1 and 2. And my recommendation would be that you squeeze the bag with your dominant hand and your mask would be on the non-dominant. There we go. We got it. Good. All right. And so 1 and 2. Airway persons, stay there. Don't lose your hold. Compressors, get on that chest.
Should we demo it?
We've already done our assessment.
Okay.
I'm going to push this a little bit closer to you. Let's do 30 compressions and then pause. When you get to your 30th compression, you just simply raise your hands. We call that hovering. And that way your airway person can see if the breaths go through. All right. 30 to 2. Let's go. Count. Don't go too fast. 9, 10, 11, 12, 13, 14. Great job. And hover. 1 and 2. Great job. Great job. I'm going to pause you all. Now we can switch out. Okay. And so it's not, and right now, it's not about the 10 seconds because I need to make sure that you two ladies know how to use these bag mask devices. And so are you right-handed or left-handed? Right-handed. I need the mask in your left hand and the bag in your right hand. All right. So here, hold on, babe. We got you. All right. So remember, this is not you rushing right now because we know that people haven't used this bag before. So this is going to be your EC. This is going to be here. Your hand's going to go on top. I'm going to actually move your body closer. And if you can have the patient's head rest against your left thigh, that's going to give you additional support. Lift the chin. Okay. And now give a breath. 1 and 2. Perfection. But if you feel like your hand's going to get tired, make a tighter seal. Okay. We got her over here, Andrea. Thank you so much. And so, Andrea, if she can watch the chest rise.
Good job.
Good job.
You continue?
I'm waiting for, okay, so where do you feel air escaping? I recommend making a baby C.
Okay.
So baby, 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 baby. All right, good. 3 fingers, open up the airway. Use your left leg to balance. So use your left leg. All right, and now give that breath. And if you bring this bag up, typically you break your seal. And your hand's going to go right here. Give a breath. Where do you feel air escaping? Okay. There we go. We got to keep the airway open now. All right,
Yeah,
so,
that's
all right, keep the airway open. Keep the airway open. 30 to 2. Let's go. 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29. All right, hover and 2 breaths. 1 and 2. All right, great job. And we're going to pause you all because this was just about you practicing with the equipment. And so you 2 ladies, what is the hand placement called when you're using a bag mask device? What is this called? You're going to hear people say EC or CE, clamp technique. You can only utilize that technique when you're actually having the bag mask device. If you are managing the airway, where do you stand? Are you on the side? At the head, and that's going to become important because you can't be over here trying to manage the airway because you'll be blocking the compressor, blocking the person starting the IV. So if you're ever in the hospital sector and you see a code, you're always going to see respiratory therapists at the bed. And so when you're establishing your team roles, anytime somebody has this bag, they should be at the head of the victim. All right, if you 2 ladies will put the bags down. So everyone has practiced chest compressions. We've practiced with the bag mask device. And now the next thing we're going to practice with is with the defibrillator. Okay. And I think for this one, you all can actually have a seat. Okay. All right, what does the AED stand for again? Okay. And when it arrives to the scene, what's the first thing you do? Turn it on. You want to power it on. Whenever you go to different corporations and teach, because a lot of us are doing this for entrepreneurial purposes in addition to helping save lives. But when you go to different corporations and teach, you want to, when you're doing your contracting, ask them to send you maybe the name and the make of their AED. So when you get there, you've already researched a video on it so you know how to utilize their AED. If not, because they said they didn't have one or whatever the case may be, when you get there and you ask questions such as, okay, tell me where your first aid kit is, tell me where your AED is. And if those 2 items are not together, that's something you want to make a recommendation for, because it doesn't make any sense to have one person running east and the other person running west. We need to get that one person to be able to bring the AED and the first aid kit back simultaneously, if possible. And then let's say they still didn't give you the information you asked for. When I'm there, when I'm doing my setup, usually I'm there earlier, I will go and look at their AED. And then I will incorporate whatever YouTube video corresponds with their AED, because I don't practice with live AEDs. I practice with our training devices. If you practice with theirs, it's live and it's only going to let you go so far because you didn't really undo their pads, because those pads are expensive. Any questions on how to conduct the corporate course and utilize the AEDs that are on site? You're going to have to incorporate some video so that those staff persons understand how to use the AED they have there. So for our training device, what's the first thing you say I do? And I'm not going to turn it on just yet because I don't want to talk over it. But once you power it on, the second prompt is going to be pad placement. And so during your classes, you can have 2 AEDs, but what I find that works is I actually allow the students to use their hands either on themselves or on their mannequins to show me the pad placement. And of course, we're opposite each other, but it'd be high right, low left with the chest exposed. When we say low left, a lot of people want to put the pad on the stomach. But the strongest part of the heart is right there at the crease of the breast. So that's where I want you to put that pad. On your own bodies, please show me the hand placement. Remember, we're opposite. High right, low left. Very good. Awesome. All right, so pretend I turned this on. It told me to apply the pads. I peel and I stick. I apply the pads. I peel and I stick. And then after that, this light's going to be flashing, telling me where I connected at. Can you use an AED on a pregnant mother? Sure you can. When in doubt, if mom's heart has already stopped, what's happening to the placenta that's feeding the baby? No blood flow. But if you can get mom's heart re-going again, we have an opportunity to save mom and this baby. Regardless, I need you to do everything you can to save mom, because if we do get her to the hospital and she's, she has neurological deficits, we can still hopefully deliver the baby cesarean delivery, or if mom is brain dead, we can keep mom alive on life support and give the baby time to grow. But if you don't do anything, we're going to lose both of them. So turn it on, apply the pads, connect it. And right now I'm just talking you through it before we actually turn it on. It is going to say analyzing heart rhythm. Do not touch the patient. I want everyone to say clear.
Clear.
Clear. When you're teaching someone who's a layperson, someone who doesn't work as part of a team, they should not go back and touch this victim until it indicates that a shock is needed. Okay, it's going to, within a 5 to 10 seconds, it's going to say, hey, shock is required, charging. And then this light is going to flash. When that light flashes, you want to still make sure everyone's clear. If someone's touching when you press this button, what happens to them? It goes through them, they get shocked. So now you have to call another code team for them. So with basic life support courses, though, we're the advanced rescuers. We're good. So when this machine says charging, we go back and we do more compressions. And now before that person presses his button, they're going to say what? Clear. They're going to press that button. There is no residual charge. Immediately we go back and we do more compressions. The machine is going to start beeping. Beep, 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 beep. What is that beep called? Metronome. What is the purpose of the metronome?
Your compression pace.
Your compression pace. And so all AEDs that correspond with American Heart Association guidelines should have that tone. So if you're compressing too fast, I just need you to slow it down, compress with that same beat that you're going to hear. Now that we've talked about it, let's actually do it. Do you mind? Okay. And I'm just going to turn the mannequin around. And so you all are welcome to stay seated. You can see it from where you are. All right, so I only listen to you.
So let me know when again.
All right, so I'm going to start doing compressions, and you just work around me or tell me to move whenever.
I'm gonna actually turn it on, right?
And you're going to turn it on. Okay. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7.
Do not touch the patient.
And because we're training basic life support providers, when it says charging, you all say compress.
Shock advised. Charging.
Continue compression.
Stay clear of the
4,
patient.
5, 6, 7, 8, 9,
Deliver
10.
shock now. Press the orange button now. Shock delivered.
Continue compression.
Begin CPR.
Slow it down. Work with the metronome.
Very good. Give them applause, everybody. Very good. Thank you so much. And I got it from here. I'm going to turn this off for classroom purposes only. And anytime you turn your AED off in your classrooms, I want you to say the same thing, because your students are going to do exactly what you do. They're going to mimic you because you're so smart and I want to be just like Miriam. And I'm just going to turn my AED off. No, we turned it off for classroom purposes only. When would you turn off your AED?
When you get to the hospital.
So let's say you're in home care, let's say you're at a nursing home. When the paramedics come, that's when your AED gets turned off, when they put theirs on. The paramedics are going to keep their AED on all the way to the hospital. With Damar Hamlin, when he recently had his sudden cardiac arrest experience, I think they said they shocked them once in the van or something like that. And so it's possible for someone to regain a pulse. You just don't take off the AED because they regained their pulse, because they could lose their pulse again. So you always want to be in an ever-ready state until we can get them to the hospital to figure out what caused their arrest. This is going to reanalyze every 2 minutes. How frequently do you and your compressor switch places? Every 2 minutes. So every time it says reanalyzing, that should be your cue for your compressors to switch out. What questions do you have about the basic use of an AED?
I have a question about the placement of the left side.
Mhm.
That's supposed to be below the breast.
Yes, it can, but as long as it's not hair there, it's not an imperfect placement, because she watching you.
Quick question too. If
Yes.
you're where your students in a complete panic and they put them opposite,
It
is that going to affect the outcome?
No, but hopefully, because most of your defibrillators now are biphasic, and what that means is that a charge is dispatched through both pads. And so I want you to think of the pads as bread and the heart as meat. And your job is to try to sandwich that meat and deliver that shock. There are studies that have come out, which I've not seen it, where they're using 4 pads. And I'm thinking that's because they can use less energy. I probably do need to read up on it, but I promise I read a lot. And so could you imagine having someone who's getting, pretty much shocked all around the chest, but maybe because it's less energy, either way, it can sometimes singe the skin. It's not a good smell, and you can peel off some skin too. So using less energy is preferred. Advanced providers will use a manual defibrillator, and that's something they'll show you on the video, but they'll also say that this is not a part of your training. What questions do you all have about the AED use? How do you use an AED if you only have adult pads? How would you use them on a child or an infant? Say it again. So they do have an attenuator, and that's just an adapter that you would connect the adult pads, I'm going to call it a connector into, and it will deliver less energy. But what about the pad placement? You have a pediatric victim and adult pads, front and back. The pads can never touch. Okay? So that's another reason why when you're at these companies, you want to see what their equipment looks like, what pads they have, because if they only have adults working there, they're not thinking about the pediatric visitor who would come, and you want to make sure that they know how to place those adult pads on that child victim. What do you do if someone drowned and you pull them out of a pool? Do you have to dry their entire body? No. If you stand in that pool of water, what's going to happen to you? So you're going to get a shock too. So you want to be mindful that water is a conductor of electricity. And even though you pull them out the pool and yes, their body has drained, you either step outside that puddle or you pull them down further so you don't worry, you don't want to risk getting shocked. Child CPR is very similar to adult CPR. For American Heart Association purposes, you can use the adult mannequins for child CPR. What age to stage constitutes a child? Age to a stage. Where does it start? 1 to puberty. 1 to puberty. And so I always give the same scenario. My son is 10. He is my height, like he's sizing me up every day. And something happens to him and he has a SpongeBob t-shirt on. Is he a child or an adult? He is an adult. Okay, so these kids are big. So even when you say 8, I have to actually see if that child has reached puberty. If they have any breast development, you look at them and you're like, man, you almost bigger than my neighbor. You have to treat that child as if they are an adult. Your numbers don't change. How many inches? 2. How fast you compress per minute? With a child, you can use one hand, but you are going to become tired if you're doing compressions with one hand. And let's say that child doesn't survive. What's always going to be in the back of your mind? So I recommend that you always use 2 hands on the child, even though you can use one if you have the upper body strength. But if you cannot compress 2 inches with one hand, go ahead and use those 2 hands on the child. Once your team arrives, let me backtrack. If a child or an infant goes into cardiac arrest, more than likely it was not due to an electrical issue. What was the cause? So once you have a team that comes, we're not going to be providing 30 compressions and 2 breaths. We're going to do 15 to 2. Why?
Increase the amount of breaths per minute.
Yes, when you do the mouth, whenever you switch to 15 to 2, you end up giving double the number of breaths, and that's going to help that child survive. Your video and your book will tell you that for a pediatric victim, child or infant, they don't have to be dead before you start CPR. It says they have to have a heart rate less than 60 with signs of poor perfusion. For an African American child, how would you know if they have signs of poor perfusion? Because we normally don't turn blue. Gums, mucosa, everybody, fingers, capillary refill. So that's pretty much universal. You're not sure, you can go for the capillary refill, just press and blanch. And if that fingernail was already peeled to begin with, and or if you know, because if you think about when someone's dying and you hold their hand, how does their hand feel? Cold. So this child is struggling to breathe. They have poor perfusion. You have now on the phone. If you're in the hospital, we're calling the code. And those pediatric, the ICU, they're going to be there right there to assist you. But we may have to start CPR on a child victim, even though they still have a pulse. How are your are your pediatric heart rates faster or slower than adults? Faster. So if this child's heart rate is normally 140 because of his age, and now the heart rate's at 60, that means it's not any perfusion, no oxygen circulating. We can start our CPR. Infant CPR. So what I did, we covered adults. We talked about child. Now let's talk about infants. An infant is from birth to puberty. I'm sorry, birth to puberty, birth to 1. And we're almost done with our review so that you all can take your first test. Correction, poor baby. Thank you so much for. All right, so if you'll go back to your various teams. All right, and so for the infant mannequins, they actually have a button on their diaper, and that's how you would power them on to activate their feedback devices. Great job. And whoever's standing at the side of the victim, I just want you to practice a few compressions with 2 fingers. Go ahead and practice for me. All right. Great rate up front. Great rate, both of you all. Okay, and now I'm going to pause you. And when I pause you, what I want you to do is I want you to change your hand placement. I want you to do 2 thumb encircling hand technique. Great job. Thank you so much, Andrea. And so you're really going to wrap those hands all the way around. Let me come back there. You're perfect up front. Okay, so here we go. If you'll watch me. Wrap your hands all the way around. Yep. All right. And so when you're in this position, this is when your 2 fingers get tired and or when your team arrives. And so if your 2 fingers get tired, you can switch out hands or you can just utilize a different technique. The goal is to compress at least 1.5 inches. And if you have to stop to give breaths, we didn't cover mouth to mouth, but yes, you can provide mouth to mouth to a family member or a friend. On an adult or a child, you would squeeze the nostrils through a head tilt chin lift. But if you're providing mouth to an infant, it's not really mouth to mouth, it's mouth to nose and mouth. You put your mouth over their face, okay, and give a breath. If you all would switch out, let the next person practice chest compressions on the infant. 2 fingers first. Great job. All right, and so let's pretend you just got to 30. Do your 2 thumb encircling hand technique. Great job. And now let me incorporate the bag mask device, and you all can stop. And I always have this disclaimer, you all. when we purchase these mannequins, it's so hard to get the infant's chest to rise and fall. So if you get chest rise, I'm so proud of you. If you don't get chest rise, I understand because I can barely get it either. But what I do know is that if this was an infant in the real world and we're not getting chest rise with the back mass device, we're more than likely going to intubate this baby. So during our classes, if you do not see chest rise and fall, do not freak out because there will be another intervention that we do in the real world. Another thing is when you had the adult, you brought that airway, that head back a whole bunch. You don't do that with an infant. You don't need your leg or anything. It's just going to be a modified head tilt chin lift, and you give 2 breaths. So mask on, EC clamp technique, open up the airway a little bit and give a baby breath. 1 and 2, just half squeeze. Okay. Okay, so she got hers over there, but it's okay. It's okay. I'm gonna open up just a little bit. Go ahead and get your placement back. Open it up a little bit. Now try. You got it. Yay. All right, you all, hallelujah. The babies are cooperating. All right, and so now if you'll let your partner practice. You all have set the bar high. And so usually if you have this back towards you, it's going to be a distraction. So the back goes to the side and now open up the airway a little. Okay. All right. These babies are cooperating today. Great job. All right. So airway, keep stay. Oh, Lord Jesus, please let these babies keep working. All right. So airway, please stay where you are. Compressors, wrap your hands around. And it's going to be 15 compressions followed by 2 breaths. Let's go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
And then 2 breaths. Great job. And let's try it one more time.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Great job. All right. And we're just going to pause. And then everybody, I still have one more question. You're welcome to have a seat. We just have to talk about choking. Great job, team. So we did adult, child, infant compressions. We know how to use the back mask device. We know how to perform the rescue breaths if we were going to utilize our mouth. If a adult is choking, we used to call it the Heimlich maneuver, but the Heimlich family sued, so now it's called the abdominal thrust. All right, and so if you're performing the abdominal thrust, would you show me on your own bodies how you perform it? Avoid the xiphoid process. Everybody avoid the xiphoid process. Good. And so what you want to do is when you take that knuckle, bring it down closer to their belly button. Imagine where their belly button is. And you're going to cup and you're going to do upward and inward thrust. Okay. And you do this until what happens? Until the object or they collapse. And this is important because when you take your test today, it's going to use a term like unresponsive choking victim, victim of a foreign body airway obstruction. Pretty much the person choked to death. The person has choked to death. They're not able to cough. Don't hit them in the back. If you hit them in the back, it just makes the object go further down. If they're communicating with you, encourage them to cough. If they can't communicate with you, they're making universal choking sign. You'll say, hey, are you choking? Can I help? Do the abdominal thrust. If the person's pregnant, you cannot compress on their belly. Would you show me how to do chest thrust? And again, avoid that xiphoid process. So center of the chest, and you want to go straight in. It's not like a sternal rub where you're going up and down. And you would do that until one or two things happen. What's the two things? Or it comes out. Okay. And you can also do that for somebody who's larger. And what I want to think about is, let's say you're in the nursing home and you're in the room by yourself with somebody and they start choking and you can't get around them because they're in a wheelchair. That's something you can also do to chest thrust if you can't get around their waist. For the babies. If you have a baby, you have a baby. Go ahead and take the baby. If you'll turn your chair so they're facing this way. All right. And whenever you're utilizing the back slaps, you're going to have the baby face down on your arm. Baby face down on your arm. The diaper should be lower. Excuse me, the head should be lower than the diaper. All right. So face down. All right. And we're going to do this. And I'm not suffocating the baby. My fingers are open, but what I'm doing is I'm actually supporting the head and the spine, okay? Because you know the babies have the larger heads. You're going to hit the back 5 times. Let's go. 1, 2, 3, 4, 5. Support the head and spine. Rotate to the opposite extremity. And now 5 chest thrusts. 1, 2, 3, 4, 5. Let's do it again. Let's repeat. Let's go. Mama's not playing over there. Okay. All right. So, oh, you're good. You're good, Andrea. Your baby's coloration's improved and everything. All right. Would you all please pass your babies? Arm, and you utilize your leg too, but we start with the face down. And so your arm is going to be beneath and supporting. Head should be lower than the diaper. Head, so gravity can help you. So bring the head down. There we go. Let's do 5 back stops. Let's go. 1. Oh, you don't have to be that aggressive. Don't be like her. Just 5 and 5. And now support the baby's head and spine. Rotate to the opposite extremity. Now that baby almost bigger than you. So turn your chair.
Are you right-handed?
Yes.
Turn your chair. All right. And so I want you to practice holding the head with 2 hands. 2 hands on the head. Oh, no, no, no. No, no, no. No, no, no.
Okay, right.
Okay, there we go. And now support and rotate. Opposite arm. Good. And now support and rotate. And rotate. Yes. And you can utilize your leg too. All right. So now we did back slaps, support and rotate. Let's do chest thrust. Utilize your leg. That baby's big. 1, 2, 3, 4, 5. One more time. Let's go. One more time. Let's go. Just 5 and 5. All right, so you two ladies, if you'll hold your baby upright, I want you to pretend that you see the object in the infant's mouth. Please show me how you retrieve the object. Which finger? She got 2 fingers over there. So try to use your smallest finger. Think of our different members, our team members' finger sizes. Try to use your smallest finger, and you want to do a little curve to try to get it out. That's your finger sweep. Can you do a blind finger sweep? No, only if you can see the object. Now, what do you do with the baby? Here's your baby. What do we do with the baby? The baby swallowed 2 things. We only got up 1. How will we know that? Take your baby to be seen. The baby now needs medical attention. Right. You were just hitting the baby in the back, holding the baby upside down. And now you're like, look, dude, I got up half the peanut. Go to sleep. No. The baby actually needs some medical attention, okay? So we have done a thorough review. Adults, children, infants, CPR, AED use, and choking. Are there any questions that you have?
Are you, just on a side note, how often are you gonna check to see if it's come up?
There was a police officer, and this is probably about 3 years ago, and the mom was in the mall and the child was choking. And that police officer was just there. This baby still had some movement, some life to him. Probably about 3 minutes, going back and forth. And I don't know what indication. I mean, like maybe after a minute you can look, but if you don't see the object and the baby still has movement, you just keep on doing this because the baby's still alive. And after about 3 minutes, whatever was in their airway must have come out. The police officer holds the baby upright and gives the baby to mom. Here you go. I've done my job. Okay. And I'm sure paramedics and everything was en route, but just kept on doing it because the baby still has some tone, some movement. If that baby becomes limp, what do you do with the baby? Start CPR. So I'm sorry I can't give you a definite answer, but just keep doing it. Okay. All right. Any questions? All right. You all power off the babies. If the light's on, put the babies on the table. We're going to stop this video.